Back. I'm the same way. If I sing, it will snow. You do not want me to sing. Can't even sing in the shower. So who?
I thought I sounded pretty good in the shower. It's just when other people heard it.
All right, having resolved our technical difficulties, I just want to start once again and welcome you all and Madam Speaker to this bill hearing for the House Health Committee. Again, I ask for your patience if we encounter any more technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel now. We do have a few virtual witnesses today, so please bear with us as we switch back and forth. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks, as sometimes these meetings can run long, and we do encourage hydration, especially in this committee. Please be sure to turn off your phones or silence them at this time. If you see members not present with us, understand that they do have meetings in other committees and bill hearings, but they are staying informed on our proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist, and please keep your questions shorter than the answers. Once again, we are going to go in the following order today: House Bill 1364, followed by 658, 1014, 515, 1012, 1015, 1048, 866, 1263, 1106, 939, 922, and 1151, subject to the availability of our delegates. Once again, our sponsors are not time limited, but please keep your testimony reasonable, and all witnesses have 2 minutes. And now we will start with House Bill 1364, and welcome, Madam Speaker, back to your
Thank you, Madam
home.
Chair, and thank you all for having me. I'm so glad that we did have technical difficulties because I missed you guys, so I was able to spend a little time with you. Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. Thank you for the opportunity to present to you House Bill 1364. So what is House Bill 1364? Why did I put it in? It's a simple, yes, I know everybody says that, but it is, yet important bill that will use information found in mammogram to save lives. This bill will require notification to women in their mammogram results letter if breast arterial calcification, known as BAC, is present in their mammogram. BAC is associated with increased cardiovascular risk. BAC is the buildup of calcium in the arterial walls that can predict or discern cardiovascular disease. BAC can appear on mammograms as distinct, thin, white parallel lines or beaded, tube-like structures that resemble a railroad track pattern. Although BAC frequently appears on routine mammograms, there's currently no standardized protocol for reporting this information to a patient. And it is really important, useful information. In addition, even when the presence is documented, reporting practices lack uniformity. This bill will provide that needed uniformity and standardize that practice of reporting the presence of BAC. The notice required by the bill is actually quite simple. Non-alarming message informing the patient of the presence of BAC and its association with increased cardiovascular risk. In 2013, this committee actually heard a bill, and it passed, that require mammogram results letters to include information related to dense breast tissue. This bill builds upon that model, which has been providing valuable health care information to women in Maryland for more than 10 years. Why is this important? Because knowledge is powerful. If you're told and you get this letter that this was noticed on your mammogram, then you can decide what to do with it. And you can go to your doctor and you can tell your doctor, hey, I received this letter and I know that BAC is associated with cardiovascular disease. What are my risks? This bill saves lives. It doesn't have a fiscal note. It's not going to cost anything. I met with all the stakeholders, and I worked with them to incorporate their expertise and their suggestions in the bill. And those stakeholders, you have the letters in the file, And they include Dr. Rachel Brand, who is the Chief Medical Officer of the Brand Foundation Radiologist, the Maryland Department of Health, and many other radiologists that work in Maryland. I am offering a small amendment clarifying that a provision of law regarding federal action on dense breast tissue has no effect on the notification language related to breast artificial calcification. It's quite simple. The science is clear. There's one testimony provided by one of the radiologist company that has all the, oh no, it's the COG letter, has all the different scientific articles written on it. It is clear. There is a relationship between BAC and when it's discovered, and it informs the patient and the doctor. So I respectfully asked for a favorable report on House Bill 1364. Dr. Brand.
Thank you very much. It's truly an honor and a privilege to be here today. Chairman Bagnall, Vice Chairman Cullison, our wonderful new Speaker of the House, and to the Health Committee. Thank you for the opportunity to speak to you today. I'm a breast cancer physician. I've spent my life trying to find the earliest, most curable breast cancers. I myself am a breast cancer survivor and have been privileged to be part of teams that have brought 4 new breast cancer technologies to patients. But today, I am here to require that every mammogram include whether breast arterial calcifications, BACs, are present. This is not a technicality. It's life-saving information that we see and readily have on every mammogram. And we have rigorous and extensive evidence to act on this, as you heard the speaker say. Breast arterial calcifications are visible deposits in the arteries that appear on mammograms. Extensive and compelling research links the presence of BACs to a substantially higher risk of heart disease and stroke, the leading cause of death in women. In fact, 10 times more women die of heart disease and stroke than of breast cancer. And the symptoms that women have when they do get heart disease is very different than the classic symptoms described in much of the literature, which is described for men. Yet if radiology reports omit this finding, an important window for prevention closes. When women leave their screening appointments thinking only about cancer, when the same image, indeed the same exam with no additional imaging, could also reveal a marker that prompts life-saving cardiovascular evaluation, risk reduction strategies, and timely treatment. Currently, there's no guidance about BAC reporting, but requiring BAC reporting is a low-cost, high-impact policy. It standardizes care. Radiologists would note the presence or absence of BAC. Clinicians would receive a clear trigger to assess cardiovascular risk, and patients would be informed and empowered to pursue proven interventions, additional evaluations such as stress tests, coronary artery CTs, assessment of elevated cholesterol, smoking cessation, and tailored medications. This is about actionable medicine, information that changes the clinical decisions and reduces morbidity and mortality. Beyond health outcome, this is an issue of equity and informed consent. Women deserve to know the information we as their physicians have about their health, not only what's convenient to report. We have the information, we owe patients the information, and we owe them a chance to act. Surveys regarding women's preferences confirm that women want to know, indeed deserve to know, this information. This legislation also gives Maryland the opportunity to lead the nation.
Wrap up your testimony?
Yes. By becoming the first state to require BAC documentation in mammography, it would allow Maryland to lead the country in saving women's lives. I urge you to pass this simple evidence-based mammography reporting requirement, and doing so will align screening with prevention, save lives, and demonstrate that our health system takes women's total health seriously. Thank you very much.
And Ms. Hopwood, are you here just for questions?
I'm just here for questions, thank you.
And Madam Speaker, I believe this is your first time testifying before this committee as speaker.
Yes.
Do our members have any questions? Are there any actual questions? All right, let me start with Vice Chair Cullison.
You can give them all to the birthday girl right here. To the left. That's quite a gift. There you go.
Thank you. Thank you, Madam Chair, Madam Speaker. Welcome to that seat. So I think my question was probably answered by Ms. Bem, but I just want to make sure that I understand that when a radiologist reads the mammogram, they have the knowledge and experience to identify that calcification so that they can, I love the way it's worded in the bill. They can make sure that paragraph just goes in the letter. Is that right? We're not asking
Yes,
for
it's a very
anything?
simple binary present, not present, and it's very easy to see. They're very classic linear calcifications on a mammogram. We see them every day.
So basically, they've always been seeing them. They've just been not notifying anyone.
Absolutely.
Thank you very much. Thank you, Madam.
Thank you.
Seeing no further questions, thank you very much for your testimony, and thank you for joining us today.
Thank you for having me, and thank you for the work you guys are doing. Remember, one question per.
Thank you very much, Madam Speaker. This concludes the hearing on House Bill 1364. We're now going to move to House Bill 658. This is the Maryland Department of Health Community Forensic Aftercare Program established. Delegate Charkoudian, if you want to first the table, and if you want to bring your panel, you can get started whenever you're ready.
Madam Chair, yes, we've got Michael Gray and Sanjeev and Robin should be here, I think. Yes, everyone's here. Okay, we're good.
What's your name? No, but that's okay.
Okay. Madam Chair, Madam Vice Chair, colleagues, for the record, Delegate Lorig Charkoudian asking for a favorable report on House Bill 658. For those of you who have been on this committee for a while, you know that I have continued to work on mental health and behavioral health bills. I come at this work with personal experience, a close family member with severe bipolar disorder, and over the course of many years have unfortunately learned quite a bit about how broken our behavioral health system has been. Some progress in recent years, but continues to be really in many ways. So that's broadly how I come to this work. Specifically, this bill builds on the work that you all did last year, which I'm grateful for, which is related to when people are determined to be not criminally responsible. And so this is this really kind of challenging area of the law, excuse me, where someone's deemed not criminally responsible, but at that point, they're not criminally responsible because of a mental health condition. And so we need to continue to treat that mental health condition to maximize the likelihood that they can be successful in the community. And what gets tricky about this area of the law is you have sort of the traditional criminal responses to behavior that is deemed unacceptable and criminal in our state, but you also have a sickness and an illness that needs to be treated. And what we know about when people are sick, and in particular when people have a mental illness, is that their participation in, understanding of, and people who matter in their lives, participation in their treatment is critical. It's a really important piece of their healing. And so unlike in a criminal case where, there's sort of open shut, and of course, relationships matter in those cases as well. But there's more complicated nuances as it relates to people who are deemed not criminally responsible and whom we are trying to rehabilitate through a treatment process. And what we know is that treatment does work. Treatment can work, but treatment doesn't always work. And so if we're going to have folks who are coming back into the community after being deemed not criminally responsible, we need to maximize the likelihood that their treatment is going to work. So right now, individuals who are deemed not criminally responsible are under the care of the Maryland Department of Health. Last year, we worked on the forensic review board process and making sure that individuals who are in that hospital and their family members, their loved ones, their advocates could participate in their treatment plans and participate in their transition plans. Last year, my bill also had CFAP related, that's the post-release related components in it, and the committee decided that was too much in 1 year, so we would move this to this year. So I've been working over the last year with Office of Public Defenders, with mental health advocates, with the Department of Health, and others to bring you this bill. And once again, what we have is the post-hospitalization process is one that has been operational for many, many years, but there's been no transparency and there's been no commitment or requirement that a patient be involved, and there's been no commitment or requirement that their patient's loved ones or advocates be involved. And so what this bill does in many ways is it just takes a process that the Department of Health is doing already and puts it into law. By putting it into law, it adds a level of accountability and transparency because for the most part, that's what happens, but this ensures that that's what happens, that everyone can see what happens, that everyone can see where they are in the process. The second thing that it does explicitly is it makes sure there is a role for a patient's themselves to participate as well as their family members. And that is the piece that's really important for a patient's long-term healing. And so you'll see in a lot of the testimony, including from the Department of Health, that a lot of this reflects what is already in place. I've worked very closely with the Department of Health on building this bill. There's still a couple of areas where they've asked for some amendments. I can speak to the fiscal note if anyone's interested in that. We're refining a couple more things, and I'm happy to take questions after my panel speaks about the details. Thank you. Why don't you go next?
Hi, I'm, excuse me. My name is Lindsay Baylog. I'm a social worker with the Office of the Public Defender in the Mental Health Division. And I work with clients all over Maryland who are conditionally released from state facilities. And I'm going to talk about the authorized agent aspect of this bill. So our office conceptualized this bill after our clients repeatedly came to us asking for our help complying with their conditions of release. We noticed a trend in these requests that our clients were having difficulty communicating with their CFAP monitors and that decisions about their treatment were being made for them and without them. Our clients would meet with their CFAP monitors periodically, and this is their opportunity to ask questions and get feedback. While many of our clients like their CFAP monitors and enjoy a supportive relationship with them, our clients nonetheless realize that there is an immense power imbalance here. Their monitor is the gateway to more freedoms, like being able to spend more time with family or loss of freedom because their monitor has recommended they go back to the hospital. Every client fears having to return to the hospital, so I'm sure you can understand the amount of pressure our clients experience when interacting with their CFAP monitors. Our clients do best when they have a strong network of support that includes family, friends, their treatment team, other community supports. Not all of our clients have such a network, so they come to us at OPD, knowing that we will advocate for them and work to help them get on track. Clients have invited me to join them in meetings with their CFAP monitor to help them advocate for their needs and to help them understand what their monitor expects from them, only to have their monitor deny me access simply because I work for OPD. Clients have informed me that their family members have been denied at times as well. This is a real disservice to our clients, as we all have the same goal, to help these folks succeed safely in the community. As you might expect, our clients demonstrate a wide range of serious mental illness, neurocognitive disorders, and intellectual and developmental disabilities. Some of our clients can easily advocate for themselves. Others cannot, and these folks should have the right to name an authorized agent to speak for them and with them in these spaces. It's their lives, their freedom on the line, and they deserve the right to be heard. Thank you all.
Chair Bagnall, Vice Chair Cullison, and members of the Health Committee. My name is Robin Yasino. I'm a volunteer advocate with NAMI Montgomery County, and I live with a mental health condition. NAMI Montgomery County is an affiliate of the National Alliance on Mental Illness. Here in Annapolis, we advocate for Montgomery County residents in partnership with NAMI Maryland. We respectfully request a favorable report on HB 658. You've heard from Delegate Charkoudian about the need for this legislation. I'd like to emphasize a key strength of this bill. Its provisions that protect the rights and the dignity of people who are deemed not criminally responsible and committed to the Department of Health. The dignity and the rights of people who may take part in the forensic aftercare program are important to NAMI, and under HB 658, they have the right to appoint an advocate and an authorized representative. That's in addition to legal counsel. These are significant added layers of protection and representation that are done with the involvement of a committed individual. We also appreciate the provision that requires the timely disclosure of records to counsel, including a 24-hour turnaround for written requests from the Office of the Public Defender in certain circumstances. Transparency and timeliness with the Community Forensic Aftercare Program's records will allow for better decision-making by the Community Monitoring Board and ensure better outcomes for people who are under conditional release. As somebody who lives with a mental health condition and has not been in this system, fortunately, when I was in various hospitals, I always had family members with me there to advocate with me. Every individual with a mental health condition, as they are transitioning from inpatient care, needs that type of representation. We appreciate Delegate Charkoudian for bringing this bill, and we thank the Health Committee for hearing our testimony. And again, we ask for a favorable report. Thank you.
Good afternoon, Chair Bagnall, Vice Chair Cullison. My name is Sanjeev Varghese. I'm the Deputy Chief Attorney in the Mental Health Division of the Public Defender's Office. We urge a favorable report on House Bill 658. One of the aspects of this bill would provide notice to the attorney of record of alleged violations and the information that's transmitted to the state's attorney currently about those alleged violations. When we are given notice of those violations and the ability to intercede and work with our clients to help them come into compliance when it's applicable or available, that would prevent rehospitalizations that are not needed. For example, technical violations such as not paying their rent or the program fees or smoking in their room or things of that nature. That should not cause a violation where they are brought back on a warrant where they're taking up a bed. Additionally, the concern about our clients being notified of their potential hospital warrant, and there's a concern from the prosecutors that we would help our clients potentially evade that warrant. We have an ethical responsibility to our profession, and we have an ethical responsibility to our courts to not do that. But we do advocate for our clients to turn themselves in, to proceed with the process. If the individual is psychiatrically decompensating, an emergency petition is the quickest way to get them into the hospital and get them the help that they need. Following up on the transparency that was discussed by the previous two individuals, the transparency allowed by this bill would, this bill would allow greater transparency for the individuals under the CFAP monitoring program to have that interaction about expectations and barriers to what goals they have and what those expectations are to achieve or overcome those barriers. We urge that favorable report. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair. My name is Michael Gray. I'm with NAMI Maryland. We are the statewide organization of the National Alliance on Mental Illness. We provide supports and services free to the community through a network of over 60,000 people living with mental health conditions, their families, providers in the community. I want to thank Delegate Charkoudian for bringing this bill, and thank the members of this committee who were on HGO last year and the General Assembly for making some progress on this issue. And as the delegate said, this is another step to get us towards the services and the continuation of services people need as they leave facilities. And this whole idea of someone being not criminally responsible is the criminal justice system in Maryland's attempt to try and recognize the fact that if a person commits a criminal offense, the action of a crime, and they do so while living with a serious mental health condition, that is not the same as someone who does not have that condition, who makes a choice to commit that criminal offense. And this whole process in place is trying to get towards recognizing that, and it's so important to have the dignity of these folks recognized as they transition away, the great work that the public defenders do and that the hospitals would like to do. And that's why NAMI supports this bill. And thank you, Delegate, again, for bringing this bill on this very important issue.
Thank you very much for your testimony. I'm going to open it up to questions from the members, starting with Delegate Kaufman.
Hi, yes. Delegate, you mentioned that you'd be willing to, and I wanted to give you an opportunity to address what the fiscal note and what you're doing to bring it down.
Yeah, so thank you for the question. I think the part that's confusing to me about the fiscal note is, for the most part, what this bill does is it codifies what's already in place. And so right now, the CFAP monitors meeting happens 2 weeks post-discharge, 30 days post-discharge, 60 days post-discharge, 90 days post-discharge, and 6 months post-discharge. So that's 5 meetings. The bill requires 4 meetings, one every 90 days. So I think if you want to continue with the current structure, which we could also put into law, in theory, the bill adds 1 more meeting. So I'm not totally sure that I understand how that's $160,000, 1 more meeting per patient, which is maybe 100 patients. So possibly that adds $160,000, but I think that in general, I don't fully understand when we are taking a practice that's already in place and putting it into law, how the price tag goes up. So there's a possibility of taking this schedule that I just shared with you and replacing the every 90 days in the bill with this schedule. I will note that the every 90 days in the bill is just for the first year, and what I just read to you is the first year of what happens. So I think, I'm not sure that the fiscal note is accurate, but if it is, and if that additional meeting, that 1 additional meeting for each patient costs $160,000 a year, and if that's a concern to the committee, then we can adjust the schedule that we're requiring the meetings to happen on.
May I have a brief follow-up, Madam Chair? Yes, I was just wondering also, have you engaged with Disability Rights Maryland on this bill?
Trying to remember, because we have a whole list of advocates that we share our bill drafting with, and I believe that they are in that list, but I can't promise you that's the case. I can get back to you, because I know there's a bunch of people in our group that we've shared it with.
Yes, they submitted written testimony, or so I'm happy to share it with you if you don't have it.
Thank you. I probably do have it here.
Thank you, Madam Chair.
Vice Chair Cullison, followed by Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate, for your work on this. Have you had a chance to read the letter from the Maryland Association of County Health Officers?
I don't think
I think their fear is that there will be more responsibility at the local level than there is currently, and that they're worried that they do not have the resources and capacity to meet the requirements of the bill. So I'm wondering if you've had if you or any of your panelists had any discussions with them around the intent and
No,
how shifting?
this is the first that I've heard from them, and sorry, I don't get the testimony, yes, so no, I
that
have
is a
not.
problem.
I'm not sure why they would. I mean, I don't think that they're explicitly named in the bill such that they would end up with more responsibility. Again, I just would highlight that what the bill does, so we sort of went to the Department of Health and we said, what do you do? And then we wrote down what they do. And then we said, okay, here's a place we want more transparency. Here's a place we want to make sure that residents get to participate. Here's a place we want to make sure residents can bring a family member. And that's kind of what we added to the what do you already do. So, and then, of course, some of the notice requirements. So I don't know how it would change local health officers' role in it. But again, I'm willing to hear from them directly.
Okay, great. Thank you. Thank you,
Yep.
Madam Chair.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate, for this good bill. I was actually going to start, but the Vice Chair's already asked that question. Do you have any idea how many people we would be talking about being in this program? And it seems like that would be lifelong, that they would be monitored lifelong. Is that my
They're not
understanding?
monitored lifelong. At some point, they stop being monitored based on their success in the program. At any given time, or right now, there's 547 people who are in the program. But I think, I'm not finding my number, but I think, as the Department of Health, they may be coming up. I think there's maybe about 100 at any given time that's in that first year, which is what the requirements are, which again, if we have to change the timing so it matches what they're currently doing here. At fiscal note, we can, but those are sort of the numbers that I understand we're working with.
Thank you.
Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for bringing the bill. I was looking at the physical note, and it adds 2 positions. So this one extra meeting, would it be given by the same people that are giving the other meetings, or would it take extra personnel?
Right, I think that's what I'm saying. I'm not sure I understand. I think it would be a good question to ask the Department of Health. I think that we saw a similar thing last year where we codified existing practice and added more transparency to it. And when they initially came in, they said they needed several more positions. And when we really walked through it with them, they said maybe they didn't. So again, if the change in the number of meetings or the schedule of the meetings would help, I'm open to that amendment. One additional meeting per person, so maybe that takes 2 people. I don't know.
Would it? Yeah, yes, Madam Chair, thank you. So would it be the same people essentially doing it?
Yeah, because
Okay,
the
all right.
CFAP, the group that's supporting or working with one individual sort of stays the same over time.
Well, that makes more sense. Physical note, thanks, that clears up. Thank you, Madam Chair.
Seeing no further questions, I will point out to the members that the Department of Health put in a letter, but they are not,
Okay.
they are not appearing before us in person. So we will ask that we get those questions answered before subcommittee. I want to say thank you for your continued work on this. And I'm going to ask that you work with the department and see if we can get some clarity on that fiscal note. But I did want to give you one opportunity to address the only letter of opposition that we received, which is from
Yeah.
the
State's attorney.
Yes. So have you seen that?
I have, and I think there may be technical fixes to it. I have to say that I am not sure that I think there's this question about the clinical decisions and who's making the clinical decisions. I think that this might be an area where, like right now, the Department of Health, as I understand it, and I'm saying as I understand, I try not to speak for people, but based on my conversations with the Department of Health, CFAP is not making clinical decisions. And so already, right, again, as I said, this, for the most part, this is taking what's being done, putting it into law, and adding transparency and participation to it. And so what this says is that CFAP not making clinical decisions would lead to more hospitalizations or more warrants, hospital warrants. That's kind of what I'm seeing here. And again, I don't know, this person might be here to testify, in which case you can ask directly, because I may not be understanding. But I think, again, I would just say it may be a misunderstanding of the bill, and/or it may be that there's technical wording changes that we can put in to address the issues, in which case I'm happy to do that. You know, we are still doing some wordsmith amendments, so I'm happy to take those as well.
But you weren't, they didn't reach out to you prior to the hearing?
I've not had
Okay.
I think that some of the folks working on the bill had reached out to them, but I didn't hear this directly from the state's attorney.
Okay, thank you very much. Seeing no further questions, this concludes this panel. We do have a favorable with amendments and an unfavorable, so we can ask those
Thank you.
questions. Thank you very much for your testimony. I have Makina Boss, Ashley O'Neill, Clara Sevi, and Philip Hans. You can come to the table and start your testimony when you're ready.
Good afternoon, Chair, Vice Chair, and members of the committee. I thank you for the opportunity to speak today. My name is Ashley O'Neill, and I am a member of AFSCME Local 266. I've worked for the state of Maryland as a licensed clinical social worker for the last 12 years, first in a treatment capacity at Clifton T. Perkins Hospital Center, and now as a monitor with the Community Forensic Aftercare Program, otherwise known as CFAP. CFAP within the Maryland Department of Health plays a critical and highly specialized role in protecting public safety while supporting the successful community reintegration of individuals found not criminally responsible or incompetent to stand trial. The professionals assigned to monitor these cases are all licensed clinical social workers who are highly experienced in risk assessment, crisis intervention, and clinical evaluation. While we do support codifying our program and the important work that we do, which this bill will allow, we are concerned about the ways in which this bill undermines our clinical experience and expertise and reduces our ability to exercise independent clinical judgment as needed. CFAP monitors frequently possess the most comprehensive understanding of an individual's psychiatric history, criminal background, risk factors, and court conditions. We are in regular communication with community providers, educating them on a patient's history, collaborating on interventions when alleged violations occur, and offering guidance and counsel as needed. While community providers appropriately advocate for client-centered goals, our role is much broader. We need to balance rehabilitation with public safety. Limiting our discretion, such as directing an appropriate course of action when an individual is in the midst of a decompensation, weakens the safety net that we have tried so hard to provide. A safety net that has historically prevented destabilization, hospital returns, and recidivism. Our work is not just administrative monitoring, and it cannot be undervalued. It is high-level forensic clinical oversight. For these reasons, we urge you to consider striking the portion of the bill that would prohibit us from making clinical decisions as needed and issue a favorable report with amendments on HB 658.
Good afternoon, Chair, Vice Chair, and members of the committee. My name is Clara Sevi, and I'm a member of AFSCME Local 266. As a licensed clinical social worker, I have worked at CFAP as a conditional release monitor for 6 years. While we agree that establishing CFAP is important, the specific mandates that this bill will place on this program are labor-intensive and short-sighted, especially without additional staffing. CFAP currently operates with 9 full-time licensed clinical social work monitors, 1 supervisor, 1 manager, and only 2 administrative staff for the nearly 600 individuals that we monitor. Once discharged from a state facility, CFAP monitors are meeting frequently with individuals and their community teams for support and to ensure effective coordination of care, and we adjust how frequently we meet based on the individual's specific clinical needs. This bill requires mandatory 90-day meetings with individuals and their mental health treatment teams during the first year of community supervision. While well-intentioned, this is redundant and unworkable without significant staffing increases. On average, over 100 individuals are discharged each year. This bill would create 300 additional meetings for monitors and understaffed community mental health treatment teams, which will greatly reduce flexibility for monitors to prioritize high-risk cases as clinically appropriate. This bill, as proposed, requires records to be provided within 24 hours to 4 business days. CFAP already receives an average of 20 record requests per month, and under current staffing strives to deliver records within 10 days, which is consistent with Maryland regulatory standards. With only 2 administrative staff for the nearly 600 individuals, compliance with the shortened timeline would be unfeasible without additional personnel and risk diversion of clinical staff from direct safety functions and monitoring in order to meet this unrealistic timeline. While we agree that establishing CFAP is important, the specific mandates that this bill would place on this program are labor-intensive and short-sighted, especially without additional staffing. For these reasons, we urge you to issue a favorable report with amendments on House Bill 658. Thank you.
Hello, my name is McKenna Baus. I am an attorney practicing mental health law. I am here representing Disability Rights Maryland, the protection and advocacy organization for individuals with disabilities here in the state of Maryland. Disability Rights Maryland supports HB 658 with its sponsors' amendments. While the Department of Health already operates a community forensic aftercare program, it does so without an enabling statute or regulations. Passing this bill will establish an enabling statute for the program and thus allow the Department of Health to create regulations to help standardize the program's practices. This bill also provides clarity on the role that program mentors play. Additionally, HB 658 ensures that individuals in the program are able to authorize an agent, other than their attorney, to attend meetings and represent their interests. By allowing participants to authorize agents, such as a trusted family member, program participants will be given a greater voice in the CFAP process. This bill also includes provisions that will facilitate communication between key parties, ensuring that individuals' attorneys and advocates are provided with information about alleged program violations and related records. This will allow attorneys and advocates to better understand and participate in program meetings, as well as ensure that the Community Monitoring Board operates with transparency and in accordance with due process. In conclusion, we strongly urge you to support this bill with its sponsors' amendments. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair. My name is Philip Hans, and I am a member of AFSCME Local 539 here as a favorable with amendments on House Bill 658. Thank you for the opportunity to speak today. Establishing and codifying our program is important. However, there are issues with what's been proposed. I've worked as a conditional release monitor for the Community Forensic Aftercare Program a total of 5 years and have 20 years of clinical social work experience in community mental health. I believe in CFAP's mission, and I and my cohort want to say what happens here. Please reference the letter submitted by AFSCME Maryland Council 3 for additional details to this testimony. The proposed involvement of an authorized agent or legal advocate in a clinical process is not appropriate. This type of involvement belongs in the courtroom if necessary, not during an internal process or when, in good faith, CFAP is working tirelessly to help keep clients in the community. When interventions fail, returning an individual to a state hospital may be the safest option. I'm concerned that the involvement of an authorized agent or legal advocate will focus solely on keeping the client in the community without fully considering risk. The following example shows CFAP's efforts to keep individuals safely in the community. One gentleman in 2025 was in the community for 6 months. There were at least 10 reported violations to the state's attorney and at least 44 contacts with community providers, the family, the client, animal control, prior treatment providers, and employers. Some of the interventions look like or may look like enhanced substance use treatment, more frequent therapy and med management appointments, medication monitoring, medication adjustments, community hospitalization, and the list goes on. The proposed bill impacts thinly staffed and already stressed community providers who will likely need to include their own legal counsel, as this puts them in a defensive stance. The insertion of legal advocates or authorized agents into routine clinical intervention meetings risks compromising rapport, among other things, an integral part of therapeutic relationships. The conditional release is meant to support treatment and recovery, and I'm concerned the above referenced elements of the bill do not support that, and again, ask that this bill be looked at as favorable from our standpoint with amendments.
Thank you for your testimony. Let me open it up to the members for questions, starting with Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to testify. I'm a little confused, and I want to make sure I have this straight. Now, is this 4 additional meetings, or is this reshuffling of existing meetings?
So currently, as I testified, we meet with individuals when they leave the hospital at a frequency that is generally appropriate for their clinical needs. The bill as written mandates meetings every 90 days, which doesn't give us flexibility to meet with individuals who perhaps need more intervention. They might need more involvement, more support for both them and the community treatment providers as well. They rely on us. So the bill, the way that it's written currently, is mandating meetings at that specific frequency.
So again, would these be 4 additional meetings or rescheduling the current meetings that are already being held?
It really just depends on the individual and their clinical needs.
All right, thank you. Thank you, Madam Chair.
Thank you. Delegate Hill.
Thank you very much, and I suspect we'll have a lot of this out if the bill comes to subcommittee. Because I'm reading, following from Delegate Johnson, that it says at least every 90 days, which I think is written to give flexibility. So what I want to ask about is, there was some compelling testimony questioning the fact that you all would not be able to make treatment or diagnostic decisions, but could make recommendations. Can you help me to understand what is your role under the current program, and how do you think the role would change under this program, which I think is supposed to simply codify what's already being done, but you seem to think it's not doing that?
So there's a specific portion of the bill that prohibits us from continuing to make clinical decisions as needed. I would say the very nature of our job is collaborative in nature. Most of the time, we are not making individual or independent clinical decisions. We're collaborating with the community providers because we are not these individuals in treatment providers. But there are times where we are meeting with frontline staff, let's say residential staff, for example, where we are the only clinician in the room. We also, as I mentioned, have the most comprehensive information about what a patient looks like when they are starting to decompensate. And in some occasions, we do need to make clinical decisions about whether to pursue perhaps an emergency petition in the community at a local hospital or facilitate a state hospital return if the risk is that high. So what we are asking for is continuing to be able to have that flexibility to exercise our clinical judgment as needed.
Okay, thank you. May I have a follow-up? Okay, thank you. The other thing is that you all spoke about the need for more personnel. And again, if this is simply codifying current practices, why do we need more professionals in it? Are we not meeting the need right now? And so, can you help me understand that? I think yes, sir.
That might be better answered by the Maryland Department of Health and what they've responded to in the discussions before.
Well, the reason I'm asking you all is you're the ones doing the work now. And was there anything here that you think, again, you've sort of testified this is what we've been doing, allow us to keep doing what we've been doing, is what you've been doing suffering from a lack of sufficient personnel, professionals to get the job done?
Our program is, I would say, stressed and really hardworking. And I think that any additional layer puts a burden on it.
Okay, thank you.
Seeing no further questions, I'm going to encourage you to reach out to the bill sponsor who is still in the room and make sure that that you can have some frank conversations about your concerns. Thank you very much for your testimony. We have one more, we have an unfavorable panel, and that's Tracy Varda, who is virtual. Do we have Tracy Varda in? All right.
Good.
And Tracy Varda, you can go ahead and start your testimony.
Good afternoon. Can you hear me?
Yes, we can.
Good afternoon. I've been a prosecutor for Baltimore City State's Attorney's Office, Mental Health Court for the past 15 years, and I've worked very closely with CFAP on a regular basis. CFAP should be regulated, but the problem with this bill is that it was drafted by the Public Defender's Office and does not take public safety into consideration. CFAP is composed of dedicated social workers who monitor and work with the conditionally released defendants. These are defendants who've been convicted of crimes, many of them violent crimes, including murder. They've been released from a state psychiatric hospital and are still under court supervision. When defendants violate their conditional release orders, CFAP works with them so they can remain safely in the community. CFAP does this by enhancing their treatment plan while considering their risk to public safety. This bill will affect CFAP's ability to do this by prohibiting their clinical decisions. This bill requires all treatment decisions to be made solely by the defendant's providers who are only concerned with the defendants and who do not take public safety into account. CFAP does an incredible job of making clinical decisions that have allowed defendants to remain safely in the community rather than be returned to the hospital. An unintended consequence of limiting CFAP's ability to make clinical decisions will result in many more hospital warrants, which will put defendants back into the hospital and put a strain on an already overburdened hospital system. Other ways the bill will create public safety risk is allowing defendants to be notified of hospital warrants before they are served, which may endanger staff, peers, and the officers serving the warrant by aggravating an already volatile situation at their placement. The agency that is tasked with keeping conditionally released defendants safe in the community should not be regulated solely by the Public Defender's Office. Instead, all interested agencies should have a seat at the table and come together to draft CFAP regulations that balance defendants' rights with public safety. So for all of these reasons, and on behalf of the Maryland State's Attorneys Association, we urge an unfavorable report on House Bill 658 as it's currently written. Thank you.
Thank you for your testimony. And are there questions from the members? We start with Delegate Alston.
Thank you, Madam Chair. I believe, was it Ms. Varda?
Yes, and for some reason, you are very low. I'm having a hard time hearing. I have my computer turned all the way up, so I'm hearing as best as I can.
All right, hopefully that's better. My question to you is, do you have any amendments to the bill? We received your written testimony, but I don't recall seeing any amendments to the bill.
So I recently was made aware of the amendments that are being proposed regarding the clinical decisions, and the amendments that I would propose would be to allow CFAP to continue making their clinical decisions. Also, the part of the bill that states that the Public Defender's Office should receive the same information the State's Attorney's Office receives at the same time, that's a concern, because I think in that case, the individuals may be notified that a hospital warrant is forthcoming, and as I stated, that is going to be a safety problem. So with amendments, and I think those that have been suggested by the CFAP members, I think in that case, then we would be agreeable. But I do think public safety needs to be taken into account, which is not as the bill is currently written.
Thank you, Madam Chair.
Thank you. Seeing no further questions, I just wanted to clarify, you're here on behalf of the State's Attorney's Office of Baltimore City, or
The Maryland State's Attorneys Association.
Okay, thank you. I just wanted to make sure that we had that correct on the record. Thank you very much. This actually concludes the testimony in this hearing on House Bill 658, and we are now going to move to we're moving around a little bit to accommodate some of the bill hearings in other committees. Do we have Delegate Vogel or somebody for Delegate Vogel? Okay, great. So we're going to move to House Bill 515, which is Public Health Local Drug Overdose Fatality Review Teams membership. You can go ahead and come to the table and start your testimony. And if you have a panel, go ahead and bring your panel.
I'm Delegate Vogel's Chief of Staff. He cannot be here right now, so thank you for letting me be here. Chair Bagnall, Vice Chair Cullison, and members of the Health Committee. I'll let our expert talk about this bill more extensively. Just a little bit of background. As currently written, the law regarding local fatality overdose fatality review teams does not provide as much guidance as to who from a hospital is most appropriate to contribute to the conversations that are being had among these teams. Often these teams are having conversations that surface systemic gaps that require executive level action, hence why other officials in public health, public safety, often send higher level officials and administrators. Without hospital leadership, often hospitals will risk being present in the conversation but unable to fully implement the changes and suggestions that are coming out of these really, really important life or death conversations. So we are here to just address that. I would lastly like to say we did meet with the Maryland Hospital Association. We recognize their concerns and have some amended language that we will send over to the committee to address their concerns as well.
Good afternoon, Chair Bagnall and members of the committee. My name is Drew Fuller, and I'm a patient safety specialist, a board-certified addiction medicine and emergency medicine physician, and I've had the honor of training and practicing in Maryland for over 30 years, with several of those years as a patient safety leader. and 6 of those years as serving on fatal overdose review teams for multiple counties. I want to further emphasize what Sean had pointed out, and I'm speaking in support of this House Bill 515. Maryland has made progress in reducing overdose deaths, and hospitals deserve credit for part of that leadership. However, mortality in our state remains high, with over 10,000 to 15,000 unnecessary overdose deaths predicted over the next decade, with the median age of 39 and 50% of those individuals having dependent children. This continues to be a serious public and patient safety issue. Local overdose fatality review teams are structured to provide a cross-sector executive collaboration so that information is provided to the state, but information is brought back to the prospective institutions. Agencies such as police, fire, EMS, state's attorney, public health departments, et cetera, designate representatives with the key word being operational authority. Individuals empowered to direct policy, allocate resources, and implement change at their prospective institutions. This bill promotes structural parity to ensure that hospital representation, which is not often done by an administrative individual, but maybe a mid-level clinician within a department, reflects comparable institutional authority. Overdose fatality reviews frequently identify system-level vulnerabilities, and correcting these issues requires executive-level engagement within the hospital system. Without this level of authority, findings may inform discussion but lack the mechanism for operational execution. High reliability is essential in high-risk clinical environments. This bill ensures that when we learn from preventable deaths, someone at the table has the authority to act. I respectfully urge a favorable report.
Thank you for your testimony. Do we have any questions for this panel? Vice Chair Cullison.
Thank you, Madam Chair. I'm sorry that I'm not familiar with the fatality review team. Tell me what their purpose is. What do they do?
Do you mind? Yes, sir. So every county in the state has a fatal overdose review team, which just meets quarterly to review several cases, maybe it's 5 cases of a fatal overdose. And it has a broad representation of high-level agencies within the county or the city. And they determine if there are any systemic issues or learning opportunities from these overdose deaths that could be forwarded to the state, but also with the expectation that information be brought back to those agencies or the hospitals, and so that those agencies can learn from these issues.
So, thank you, Madam Chair. So I just, the bill currently calls for, the current law requires a representative of the hospital who has had the on-the-ground experience. I'm wondering if the high-level administrators of the hospital have that experience. Well, first of all, I'm not sure they have the availability, but secondly, the on-the-ground kind of experience.
Yeah, so, and that's where, when we met with the opposition testimony, totally valid points to be brought up. So the amended language that we can send to you later today that I have before me, we leave the hospital representative as is, because for many hospitals that does serve a vital function. Right. But for a lot of, especially in less populated counties, hospitals don't always have that in-house expertise, which makes the administrator level even more important, that somebody with that like systems level change ability is present at these conversations. So the amendment leaves alone that hospital representative and adds a new team member that would be at that administrative level. It's, again, the intent of the bill is not to limit who can or cannot be there in terms of like hospitals are sending often folks with very valuable, including at the clinician level, experience, but we're lacking currently that overarching healthcare system representation at the overdose review teams.
Okay, well, I'll be interested in the amendments. Thank you.
Delegate Hutchinson.
Thank you, Madam Chair. Thanks for being here. So just seeing that you're making an alteration that does involve hospitals, did you consult with or involve the Maryland Hospital Association? And if so, why or why not did you?
Yes, we did. So we recently just met with them, and I believe they're here today. And so we've started that conversation and are open to having it still and continuing to work on the right language that would address their concerns regarding who they're sending to these overdose review teams. But yeah, so we have had those conversations, open to continue having them and make it correct so that our intent does not necessarily restrict what they're currently doing, their current best practices, but just, again, being more collaborative and ensuring that these review teams are having the most impact that they could possibly have. They only meet like 10 hours over the course of a year, so ensuring that the right folks are at that table.
Okay, thank you.
Delegate Alston.
Yes, I was just wondering if you would explain what problem you're actually attempting to solve with this legislation.
Yeah, it's not unusual for these fatal overdose review teams to have high-level agency heads from various divisions there that can come back and make change. The hospitals, however, it's not clearly defined who or is going to serve. And the clinicians that have often been sent, maybe a staff nurse from an emergency department or a PA, who can provide some clinical insight, but they have no institutional authority. So they have no really impact when they go back to their institutions and when they've identified a gap or a problem to make change within their institutions. I'm sensitive to the fact that I was chief safety officer for a large emergency medicine group that staffed 23 hospitals in Maryland and Virginia, and appreciated the impact of the clinicians, but really appreciate the fact that it needs institutional authority to make change.
Okay, Delegate Hill.
Thank you, and I guess I'm going to, after that answer, go back to a little bit of what the vice chair was asking about, because I'm also not familiar with these fatality review or fatal overdose. What is the charge? In other words, you seem to, what you're testifying to is that, to Delegate Austin's question, the goal is to have someone in authority at the hospital who can make the changes, but there's no step here that I can see, something missing, where you all make recommendations. So I'm not understanding what the role of the review committee is and why you need a representative with that authority as opposed to making the recommendations and let them process the recommendations and decide if they're going to accept them.
I think there's multiple charges, and one is for the committee as a whole to make recommendations to the state, and so they'll often do that, and they may even have subcommittees that have some working groups within that county. But the also implied charge is that you can go back to their prospective institutions and advocate for necessary changes within those institutions if a gap was identified.
And just to clarify, the biggest charge that they have, sorry.
One question, one answer. Do you want to ask
May
a follow-up?
I follow up?
Retract my answer.
Right, and so I'm going to ask you to finish what you're saying, except as part of the answer, explain whether you all actually give reports to the hospital for them to consider rather than just count on a member of the team to take it back to them for change. So you wanted to add something.
So these are confidential discussions, and so reports can't be given back directly, but the intention is that if there's a person of authority, that they will get it, if you will, and understand where they need to strengthen up an operation or change a policy.
Okay, thank you, Madam Chair.
Thank you. Seeing no further questions, we do have one unfavorable. Thank you very much for your testimony. And we have Natasha Mayhew, if you can come and give your testimony. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee, and Natasha Mayhew here on behalf of the Maryland Hospital Association in opposition to House Bill 515. I do want to take the time to thank the sponsor and the stakeholder for talking with me yesterday about the bill and their underlying concerns, that hospitals aren't sending who they believe are the right people and need some additional guidance. We respectfully disagree. We have no indication that there are any systematic issues, as no concerns have previously been raised with hospital representation. We disagree that senior level vice presidents, chief medical officers are appropriate representatives, particularly given that they focus on high level system-wide operations. And we we also disagree that legislation is the appropriate mechanism to resolve the issues. If there is a specific issue with a specific board, we want to address that problem. And we're more than willing to continue working with them to address a specific issue without statewide changes. Hospitals strongly support the local overdose fatality review teams and share the goal of preventing overdose deaths. We value the work and we take these roles seriously. In practice, hospitals often designate subject matter experts, such as pharmacists leading opioid stewardship, addiction medicine physicians, clinical program directors in these roles. They have direct, relevant experience, are deeply engaged in the review teams. This bill excludes them solely based on their title. For example, for the Baltimore City Board, it would exclude the Johns Hopkins representatives. One is the director for the Division of Addiction Medicine. The other is the co-chair of Johns Hopkins Opioid Stewardship Committee. Additionally, Maryland Health Department's 2019 report on these local overdose fatality review teams shows that hospitals are among the agencies with the most consistent engagement and ability to give information. Again, we have no evidence of a statewide problem, and so for these reasons, we request an unfavorable report on House Bill 515.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony. This concludes the bill hearing on House Bill 515, and we're going to jump to House Bill 1048 because I just saw Delegate Shetty. So this is Public Health Chain Restaurants Sodium and Added Sugars Warning Icons. You want to come to the table and go ahead and bring your panel, and you can begin your testimony when you're ready.
I think, Madam Chair, our sponsor panel is coming. I'm going to keep my mask on just because I'm at the tail end of a cold, and I don't want to get anyone sick at the table with me.
Absolutely. Whatever your comfort level is. Welcome to the Health Committee. So,
thank you.
Thank you for your consideration.
Yes. I'm masked up. Hi. Okay, thank you so much, Madam Chair, Chair Bagnall, Vice Chair Cullison, esteemed members of the House Health Committee. For the record, my name is Emily Shetty. Thank you for inviting me to my top favorite, #1 favorite policy committee in the General Assembly. Thank you for the opportunity to provide testimony in support of HB 1048, which requires the Maryland Department of Health to regulate the sale of foods high in added sugar and sodium at chain restaurants. So what this bill will do is it will require an educational campaign by the Department of Health to help teach the sort of like what the nutritional value is of high sugar and high sodium laden foods. After that, the department will come up with some regulations on how a restaurant, a chain restaurant only, not smaller restaurants, chain restaurants, would be required to place a small little icon next to items that have over 50% of your daily added sugar or salt content, just per item. And so some of you may remember last year I brought a bill related to adding a minimal sugary beverage tax. We had a really fun hearing where I brought like cake and, a big gulp and some cookies I made. So I apologize. I didn't bake for you all today, but I did bring you the next best thing, which is research. This binder is full of peer-reviewed research on sugar and sodium labeling and why it's important to have. This one is on some of the health impacts of artificially sweetened beverages. And then this one, these are recycled from last year. This whole binder, if you can see kind of just like how many pages there are here, this is on sweetened sugary beverages and kind of some of the impact on our health. And so, oops, sorry for getting in your space there. So I bring this to share with you that not only is this kind of a public health benefit bill and an individual health bill, but it is an individual education opportunity for all of us to have informed dining. It's important when we go to consume food at at restaurants, that we know what we're eating, and what this bill will do is it will provide that type of education. So the evidence against excessive consumption of added sugar and sodium, it's overwhelming, as you can see by my nice little pile here. Excessive consumption of added sugars is a significant public health concern. Most Americans consume their share of added sugars through sugary beverages, which contain more than a day's worth of added sugars. Obesity, diabetes, heart disease, even strokes are all linked to sweetened beverage consumption. They offer no health benefit or fulfillment. They're a treat, which no shame in that. I'm a big fan of treats, sugary and salt ones at that matter, salty ones at that matter. But they're an indulgence and we should treat them as such. And so what this bill will do is it'll add some warning labels. I want to emphasize that this is information that chain restaurants already have. They would not be required to test their products and their menu separate from the nutritional testing that they're already required by federal law to do. And so most restaurants, they keep this information kind of deep inside like a website buried somewhere. But truthfully, when we're at a drive-through or standing in front of a menu and we're about to order at a chain restaurant, like very few people pull out their phones. I do because I have food allergies, so I look for that like super deep in the website nutritional information. But what this will do is it will make it prominent. It will allow people to see what they're consuming, and they can make informed dining decisions. I want to add that a number of restaurants are already doing something similar. Like many restaurants put like heart healthy symbols on their menus so that you can see that you're making a heart healthy choice. This is a little bit of the opposite of that concept in terms of allowing diners to make an informed decision to choose or not choose something that is potentially half or more of their sodium or sugar content for the day. So this would not prohibit the sale of these items. It would not change anything about what restaurants are allowed to carry or charge them anymore to do so. It just gives consumers just a little bit more information as they're making their selections. With that, I'd like to turn, Madam Vice Chair, if I may, to my sponsor panel for testimony. Thank you.
Thank you. Good afternoon, Vice Chair Cullison and members of the committee. My name is Laura Hale. I'm the Director of Government Relations with the American Heart Association, and we stand in strong support of this legislation. Excess sodium raises blood pressure and increases the risk of heart disease and stroke, which are the leading causes of death in Maryland. 1 in 3 adults in Maryland already have hypertension, also known as high blood pressure, and excess added sugars contribute to heart disease, obesity, and type 2 diabetes. People often do not realize how much sodium and added sugars are in a meal at a restaurant. One study found that up to 90% of participants underestimated the levels of sodium in their food. This means that people are worsening their health without even realizing it at the end of the day. While some nutritional information is widely available, trying to dig through the dense PDFs is really difficult. And as we think about our older adult population who are often very keen on paying attention to their health outcomes, this is almost impossible for them to do. Having it right there on the menu makes a huge difference. As well, this bill, we fit within the current enforcement structure guidelines that restaurants already comply with. We also know that this will work. At the end of the day, we've seen that informed dining has worked in other places in this country, including New York City and Philadelphia. And from the research, separate randomized controlled trials showed that people who are provided with informational labeling regarding sodium and added sugar chose to avoid those items and made better health outcomes. And we also saw decreases in hypertension rates, especially among the African American community in New York. We urge a favorable report on this legislation. Thank you.
Good afternoon, Chair and members of the committee. My name is Dr. Deanna Nera, and I am a licensed nutritionist and campaign manager with Center for Science in the Public Interest. We are a nonprofit consumer education and advocacy organization that's been around since 1971, and we are respectfully urging a favorable report for HB 1048, also known as the Informed Dining Act. So the Informed Dining Act is, as you've heard here and with these binders on this table, a science-based transparency policy. The Dietary Guidelines for Americans recommends limiting our sodium intake to 2,300 milligrams and our added sugars intake to 50 grams per day. The average fast food meal, default meal, has over 2,100 milligrams of sodium and over 68 grams of added sugar. So in one sitting, you could consume more than up to your entire day's worth. As we've already heard, in Maryland, more than 1 in 3 adults has high blood pressure, and about 1 in 8 have diabetes. These are preventable, diet-related chronic diseases that these place a serious burden on our families and really our healthcare system as well. We know that more than 70% of sodium Americans consume come from packaged and restaurant foods, and consumers consistently underestimate the sodium and added sugars. We also know that while calorie labeling is on the menu and very important, it does not signal exactly the full story. We have 2 menu items that could have very similar amounts of calories, would be very different, dramatically different levels of sodium or added sugars. As we've already heard, restaurants already have access to this information. Large chains like McDonald's, Taco Bell, KFC, and Dunkin' are already publishing added sugars and sodium, but unfortunately only online. As a mother of 2 children, I can tell you how complicated it is to go into a restaurant and have 2 screaming children trying to figure out what I'm about to order. HB 1048 simply ensures that when an item contains half a day's worth of sodium or added sugars, this is clear at the point of purchase. It does not ban products. We are not restricting choice. It strengthens informed decision-making. And so we're gonna have an example. I know Delegate Shetty did not bring her cake, but I'm going to show you what this looks like in packets. So this would be for a smoothie bowl from a place called Smoothie King, which as a nutritionist, I can tell you consumers think it's a healthy choice.
You do need to wrap up your testimony.
Can I count my packets quickly? Okay. So we're gonna count this out together. I'm gonna start. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We're going to stop there because that was your whole day's dose of added sugar or recommended limit of added sugar. But this menu item goes further than that. 13, 14, 15, 16, 17. And this isn't a menu item that many consumers would think is very healthy. And this is what we want to inform Marylanders about. And with those reasoning, Center for Science in the Public Interest urges favorable reporting. Thank you.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and the honorable members of the Health Committee. My name is Reverend Gail Harris-Berry, a minister, a community health advocate, and a proud volunteer with the American Heart Association. I serve older adults, families, and congregations across the state, helping people live fuller and longer lives through healthier choices. Every week, I sit with seniors who are managing high blood pressure, heart disease, and diabetes. I hear from other caregivers doing everything they can to help keep loved ones safe. And I speak to many people who believe that they are making healthy choices at restaurants only to find out later that a single meal contained more than an entire day's worth of sodium and added sugar, as we saw in our demonstration. The Informed Dining Act gives people something simple but powerful, the right to know. This legislation would require chain restaurants to place a clear label next to the menu items that contain more than 50% of the daily recommended sodium or added sugars. Nothing more, nothing less. Just honest information at the moment when people need it most. For the communities I serve, especially our elders, including my parents, this matters. High sodium contributes to high blood pressure, a leading cause of stroke. Excess added sugar increases the risk of heart disease and diabetes. These are not abstract risks. They are the very conditions my congregants pray over every week. We're not asking restaurants to change their recipes. We are simply giving people transparency so that they can make informed choices for themselves, their children, and their parents. When people know better, they do better. It's just that simple. And healthier choices lead to healthier communities. I am a 5-time heart survivor, also pre-diabetic, and someone who has dedicated my life to ministry, service, and health. We have to change the narrative, and as it relates to food behaviors, and I believe this bill represents compassion in action. I believe you can agree it empowers families, protects the most vulnerable.
Can you please wrap up your testimony? Thank you.
And supports a stronger, healthier future for our state.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, I'm Abby Snyder here today, not in my capacity with the Baltimore Jewish Council, but as a daughter who lost her father in September after a long battle with diabetes, chronic kidney disease that ultimately led to kidney failure. I am so sorry. My dad's history with kidney failure was a bit more traumatic than others. Until he was ultimately put on dialysis in 2023 following a heart attack, we as a family spent 4 years intensely monitoring his sodium intake to try and manage how much fluid his body would retain. While some folks might experience fluid overload and a bit of shortness of breath and the need for more than their regularly prescribed diuretics, my dad suffered from a relatively rare condition called flash pulmonary edema. Whenever his body started becoming fluid overloaded, within seconds, his lungs would fill completely with fluid. And my mom and I would be praying that the at-home oxygen was enough to sustain him while he was practically drowning until the paramedics arrived. This resulted in many weeks-long hospital visits and very scary moments of uncertainty. My mom and I spent those 4 years cooking nearly every meal at home so that we could monitor my dad's sodium and fluid intake to prevent these episodes from happening. But there are just some times when you're too tired to cook, or maybe you want to go out and celebrate a birthday, a promotion at work, or you decide to venture out to a restaurant. Having the high sodium and sugar content indicators available on menus when we would go out to eat would have been so incredibly helpful on my dad's journey. Not just for his health and safety, but also just for peace of mind and the ability to make informed decisions. No one wants to be forced to order a salad with grilled chicken without salt every single time that they go out to eat just to feel safe. By requiring these high sodium and sugar content indicators for menu items at chain restaurants, Maryland would be aiding people like my dad to be able to feel a bit of normalcy amidst their various health journeys. Thank you to Delegate Shetty for bringing this bill, to Laura Hale from the American Heart Association for showing it to me, because being here feels like a small way that I can honor my dad by ensuring that we have access to tools for others that he didn't. For these reasons, I urge a favorable report. Thank you.
Thank you for your testimony and for sharing your very personal story. We're certain that your dad is extremely proud of you.
Thank you.
I'm going to open it up to the members, starting with Delegate Kaufman.
Yes. Delegate Shetty, am I reading your bill correctly that in no way does this bill restrict what restaurateurs can serve, either food-wise or beverage-wise? It doesn't restrict what's on their menu at all?
That's correct, Delegate. All it would do is require them to provide some information to consumers at the point of sale.
Brief follow-up, Madam Chair? Thank you. And isn't it possible that a restaurateur's business will increase once they do this because people like dining at places where they have all the accurate information they need to make a good choice?
I would hope so, yes. I think that's an accurate statement, yes.
Thank you, Matt.
Thank you, Delegate. Delegate Warman.
Madam Chair, and thank you so much, Delegate Shetty, for bringing this important bill. I'm a diabetic, and my dad watched his grandpa die of a diabetic coma right in front of him when he was 7 years old, and this would have made a big difference. The bill defines high added sugar content as 25 milligrams or more of added sugars per serving. But when I Googled how much is a serving of sugar, it says it's 25 grams. I just want to clarify, and then when I Googled how much is 25 milligrams of sugar, it said it was a negligible amount. Are we talking about milligrams or grams when it comes to the high added sugar content?
It should be grams.
It should be gram, okay.
Looks like a typo.
Yeah.
Okay, yeah, that's what I
Thank you
thought.
for the flag.
Milligrams would be challenging.
Yeah, okay, just wanted to clarify that, thank you.
Thank you.
Thank you. Delegate Hill, I'm sorry, Delegate Ross, followed by Delegate Hill.
Nope. I would like to speak, but my microphone doesn't. Let's see. Okay, thank you, Madam Chair. And thank you, Delegate Warman, for that important clarification. I too zoned in on that. This is a great bill. I believe a lot in what you're trying to do. And my question, though, has to do with the artificial sweeteners and sugar substitutes. It looks like it's not a part of the bill, and so just wanted you to speak to, I know the research on that there is research, but it's not as definitive. So can you just talk about why that was excluded, if indeed it is? Thank you.
Yeah, so currently in the federal guidelines, there is not a limit for artificial sweeteners. There are, we urge people to limit them, but there is no official limit that has been just given by the Food and Drug Administration and USDA.
Delegate Hill.
Thank you. Delegate Chetty, thank you so much for the bill. As I'm reading it, I want to be clear I'm understanding that you're not saying that you're asking them to tell for each food item, like we do with calories, how much sodium, or how, you're saying this falls in the category of high. You talked about symbols. It can be up on the display board if it's a fast food place, and they take it from there. And so the question is, why is this better than, for instance, having language that says, if we refer you to this website, we refer you through this QR code if you'd like to know if our items have high calorie, or sugar or salt. Why not just refer them in the location to the website?
Thank you, Delegate. That's such a great question. Truthfully, it is really hard to find that information online when you are making the choice in the moment. And so the purpose of this effort is really to give consumers that education in the moment that they're making their decision versus having them go seek the information, which could then dissuade them from actually getting the info they need. I think in some circumstances where a consumer might be particularly highly sensitive to sodium or sugars, they may go and seek out that information online. But this should be available for everybody to see very readily, because added sugar and salts affects all of us. And that's why there is a daily limit recommended.
I'll just also add.
I think they only do one.
Oh, okay, sorry. It's okay.
Delegate Morgan.
Madam Chair, I wanted to ask the delegate, so do you think that ultimately this problem could be solved through technology instead of pushing a mandate onto businesses to disclose this? And here's the reason why I say this. Technology is solving a lot of problems. I have this great little AI app. I snapped a picture of my lunch, showed that I had 6 grams of sugar, and wait for it, 1,200 milligrams of sodium. So it was a big one. But ultimately, shouldn't this fall on the person that's concerned about this?
I love the idea of using technology as a supplement to helping us make dining choices. I have a number of apps that I use on my phone as well to monitor gluten content at different restaurants because I have a really severe gluten allergy. And so I can totally appreciate the incredible value the technology has and plays here. I will say that there are a number of people who are just tech averse, right? Who may not have access to cell phones, who may not have access to a smartphone, who may not be really savvy, right? And some of those people also happen to intersect with some of our elderly population who most need the access to this information. And so, I wouldn't want to put us in a position where we could have this information available to those who most need it, like our seniors, but they have less ability to access the technology and wouldn't have it otherwise.
Thank you.
Thank you, Delegate.
Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for the bill. I just wanted to get some clarity on the scope of the bill. On page 3, line 18, 19, and 20, it talks about chain restaurants. mean a food service facility that is part of a chain with 20 or more locations doing business under the same name. So is that 20 or more locations nationally or 20 or more locations just in Maryland?
Nationally, this is the definition for chain restaurant that already exists in state law. We copied it from
Okay.
another section of
All
code.
right, thank you. Thank you, Madam
Yes.
Chair.
Thank you. Seeing no other questions, I just had a question, I think, from Ms. Hale. You had spoken to the research that you had done in New York. Was there any adverse outcome for the restaurants that or any recognizable?
No, there was not. Not for the restaurants.
Thank you very much. Oh, Delegate Shalega.
Sorry. Thank you, Madam Chair. Thanks for being here. What is the penalty for noncompliance?
Oh, thank you for that question. We do have that in here. Hold on. I believe it is listed in, yeah, so that's existing law. So the penalty for first offense is a fine not exceeding $1,000. So if you look on page 5, the section starting with line 29 through 33 till the next page. So first offense is a fine not exceeding $1,000 or imprisonment not exceeding 90 days or both. Second offense, a fine not exceeding $2,500 or imprisonment not exceeding 1 year or both.
And who's going to administer the penalties? How would a restaurant have this adjudicated?
It's through the typical.
Department of Health?
Yeah, the Department of Health through the typical enforcement process. When they come in to do their
Sanitation.
compliance, when they do compliance checks, it would fall within the typical scope of enforcement.
Or somebody could report them, and then the Department of Health would come out? Is that as well?
Could be. It's not explicitly put in, but that's a great idea.
Thank you.
Seeing no further questions, thank you to this panel. We do have an unfavorable panel. Sorry, I'm jumping around here. So if I can bring Kaylee Locklear, Melvin Thompson, and Gary Cohen to the table, and you can go ahead and give us your testimony.
Thank you, Madam Chair, members of the committee. I'm Melvin Thompson. I represent the Restaurant Association of Maryland, and we are opposed to this legislation. And I did bring a restaurant operator with me here today who can talk about some of the operational issues. But chain restaurants, as we've heard, already comply with the federal menu labeling requirement, which includes information about sodium and total sugars with other nutritional information. And we believe that state-specific sodium and added sugar warnings would undermine national uniformity, create a patchwork of inconsistent thresholds, and potentially also confuse consumers when nutrition messages differ by state. With regard to added sugar, unlike packaged foods, federal menu labeling law does not require chain restaurants to disclose added sugars. Only total sugars are required. Calculating added sugars is more complex and requires ingredient-level data and constant updating. Added sugar is also far more difficult to calculate and maintain accurately in restaurants than in packaged foods. And I also want to draw your attention to a letter of information from the Maryland Department of Health that kind of underscores the fact that the benefits of this legislation are unclear. According to information from the department, data from the New York City sodium icon rules show that the overall impact on consistent behavior change and product reformulation has been limited and mixed. And the department's letter goes on to say that evaluations found no significant decline in the proportion of consumers selecting high sodium items and little evidence of widespread industry reformulation, suggesting that awareness-based strategies alone may not reliably produce sustained behavioral or structural change. And it's for those reasons that we oppose this legislation, but we would be willing to further discuss this issue with the bill sponsor and the other stakeholders. Thank you very much.
Good afternoon, Madam Chair and members of the committee. My name is Gary Cohen. I'm the Executive Vice President of Glory Days Grill. We have 7 locations in the state, and I'm here today to oppose HB 1048 as drafted. In 2018, the FDA implemented federal standards to ensure chain restaurants post and disclose calorie counts and nutritional information for all menu items. This requirement includes the listing of sodium and sugars on every menu item. All of this information has been available to consumers since then and is generally available on websites or QR codes. When individual states attempt to change this longstanding FDA rule by insisting on additional requirements in their state, it takes away from the federal uniformity on this issue. Most chains operate in multiple states, including my own, and have different rules in different states becomes administratively burdensome. The cost of reprinting menus is very expensive, and hiring nutritionists to further evaluate our menus is extremely costly. At a time that all restaurants are struggling for survival among so many other cost increases, we view this requirement as unnecessary since the information is already readily available. It is my experience that almost 70% of guests modify menu items to their liking, and this can greatly change the numbers that are posted on a menu. Adding condiments can also change the numbers. For example, an average order of French fries in my restaurants is 250 milligrams of sodium, but simply adding a teaspoon of ketchup to that would double the amount of sodium. There's 250 milligrams in Heinz ketchup. This is a consumer choice and can't be controlled by the restaurant. There is some research that shows that menu icons alone did not significantly change consumer habits. People choose menu items based on taste profiles, price, or just personal habits. Consumers are smart. I can't tell you how many people come into our restaurants and ask for menu items to be changed. They want it with no seasoning, or they want it with no dressing, or they want it with no sauces. They modify orders due to their tastes or their medical requirements because they have already looked at other information, and they are generally careful in this regard. Also, many items are shareable, and that also
Can you
dilutes.
wrap up your testimony? Thank you.
Anyway.
You can finish your thought.
Warning labels on menus to educate the already educated public is redundant and already available and has been for many years. This is why I'm in opposition to this bill.
Thank you for your testimony. I'm going to open it up to our members for questions. Delegate Kipke, followed by Delegate Rowe.
Thank you, Madam Chair. To whomever is most eager to respond, I did a quick analysis of restaurants opening and closing. And Maryland is doing pretty well with new restaurant opening. New York in the last year has seen a sharp decline or increase in restaurant closures. It says unusually high turnover, leading to a net trend in recent months over the last 12 months. And it cites high rent, labor, and regulatory burden as the main contributors to the problems there. We share some of those issues here, not to mention extremely high utility bills. But could you, my concern is, we have a lot of rules and regulations in the state of Maryland. Makes it difficult to operate in our state, and could you provide some feedback and your perspective on that? Thank you.
Yeah, I think it's very, very difficult to operate. Restaurants, we all know restaurants operate on small margins. We've all heard that 1,000 times. It's a very difficult business to run, especially when the government puts in new rules and regulations that become burdensome. The biggest one, of course, is labor and changes to labor regulations, increase in minimum wage, removing tip wage. Those are all things that are probably at the top of the list. I would consider this item a smaller item on that list. It's just another regulation that would require us to spend additional resources and reprint. A typical menu to reprint is $4.50, and we put 1,000 menus into a restaurant every time we reprint it. So there's a cost to doing this, and it's not that I disagree that we want to keep the public educated. I just believe that the information is already there, and this is just another unnecessary step.
Delegate Ross, followed by Delegate Taveras.
Thank you, Madam Chair. And just to your last point, I absolutely don't agree that it's an unnecessary step. I would just say, my question is, the dietary guidelines for Americans that this bill is based on do not typically conflict with the federal requirements, the labeling requirements. Can you just, they may be adding some additional things, but they don't conflict. They're aligned. So can you just clarify that there is no, and if there is, then enlighten us on what the conflicts are between the two? I think that was the first
Yeah, there
witness
is.
you alluded to that.
There is no conflict on the information. The conflict is on whether we need to put an additional step, meaning an icon next to a menu item. So if we had to do that, we'd have to reprint the menu. I'm a really big believer in a smart public. Public is very well informed. And I know that if I have high blood pressure, I shouldn't go to a restaurant and order a fried fish. It doesn't make sense. Whether it has a lot of sodium or not is almost irrelevant. I think the consumers are very smart, and I think putting an icon on the menu, well, I don't think it could hurt. I just don't think it's necessary.
Okay. Can I just one quick follow-up to that, if I can? Can you just clarify, because I do want to fully understand the hardship for these restaurants. When I look at this bill, it gives a year for you to get ready to do this. Can you just clarify exactly how you would go about implementing and doing this? Would you need to have somebody who is trained and familiar with how to count the added sugars and for the menus, what exactly would be required for you? There's lots of ways now, digital QR codes, there's paper menus, things that restaurants are doing so that they can update those.
Answer the question.
So they can update those menus more often. Can you just elaborate on that?
I think that, there's a couple of steps. One, we'd have to reprint the menus. Number two, and all of the additional periphery menus, carry-out menus and all of that. The other thing is, my understanding is on the added sugar issue, the federal guidelines right now require us to put the total sugars in the nutritional information. So now we would have to hire a nutritionist. I don't know the cost, but I'm sure it's not cheap, to go in and dissect every one of our menu items to define what's the total sugars and what's the added sugars. So there's a big step there. I don't know the cost of it, but it's not impossible. It's just difficult.
Delegate Taveras.
Thank you, Madam Chair. Mr. Thompson, what's the degree of immigrants that work in the restaurant industry?
And thank you for the question. I do not have that information in front of me, Delegate, but I'll be happy to research and provide you with an answer to that question.
Well, I know that in New York it's over 60%. Thank you. Can I just get a follow-up real quick? Yes, ma'am. With regards to this, would you think that you needed more time in order to, so that you could save or at least control some of the menu cost issues?
I don't think it's a question of time. It's a question of the inconsistency by creating statewide standards versus the federal policy for consistency that we have right now. That is a concern for chain restaurants that operate in multiple states. There is also some concern about the overall health benefits, which I mentioned from the letter from the Department of Health regarding the data in New York City. And so there was no consistent behavioral change there. And so we're not quite sure that such a policy would be worth the cost and expense and burden on restaurants if there's no quantifiable public health benefit. And I'll get the information you requested to you, ma'am.
Delegate Shalega.
Thank you. I have a quick question because of what my friend across the way said. Do you think you would have to print this in multiple languages to comply? I mean, could that be something that would then be more confusing to a consumer?
I mean, we don't currently print menus in different languages,
Okay.
so no.
So this is the language they want you to print. The high sodium content warning icon indicates a menu item with, this is quote unquote, going on your menu at the point of selection. The high sodium content warning icon indicates a menu item with a sodium parentheses salt content that exceeds half the total daily recommended limit. Diets higher in sodium are associated with an increased risk of developing high blood pressure, which is a major cause of heart disease and stroke, period, end quote. Mr. Cohen, what do you think your consumers would read that? And do you think, I mean, I understand the sponsor of the bill is concerned about health, as we all are today, but do you think that would help a consumer?
Honestly, no, because there are other already required warnings on menus. I'm paraphrasing. Right now, it says eating raw or undercooked seafood is dangerous for your health. Yet I don't think anybody has ever, people are in the mood for fish, they're going to order fish. Same thing with a medium rare burger. There are some states that make burgers cooked under 140 degrees illegal. But right now, I think consumers are getting smarter and smarter and smarter. And they know, I mean, I have a neighbor that I go out to eat with at least once a week, and he can't eat salt. And every single time, he takes control of the situation. He tells the waitress, I have a salt adversity. Please don't salt my French fries. And please put all my sauces on the side. And this is just an example of what educated consumers do. I don't think putting more warnings and more icons on menus will make that much of a difference.
Thank you.
Delegate Morgan.
Thank you, Madam Chair. I guess my question is for Mr. Cohen. First, I've eaten at your establishment a few times. Thank you. But I've never visited your website, and I wanted to give you a compliment to start with. Right underneath menus, you have nutritional information that opens up into a PDF of 18 pages of every single thing that you could possibly have on your menu, and broken down every nutritional fat from trans fat to saturated fat. I mean, this is like, maybe I should get more restaurant websites beforehand. Maybe I'll lose a little weight. But I guess my question is more of a practical one. For how do you work your business? Now, do you offer specials? And if you did do a special, you'd have to change that up.
Yeah.
And as far as nutritional, how often do you put out specials, and how many, and what kind of, how earnest would that be on your business plan?
Yeah, so that's a great question. We do seasonal menu items. If you've been a regular at my restaurants, we do them 4 to 5 times a year. And my understanding in reading the detail of the bill was that this bill would not apply to items that are available for less than 60 days. So they would be excluded.
Okay, thank you. Brief follow-up. Man, I got a great place in Charlotte Hall. If you want to come down, maybe open up another branch.
We'll talk later.
Thank you.
Seeing no other questions, I just want to clarify what the opposition is, because I'm a little confused, and there is no written opposition. And in fact, I would appreciate if we could get that letter from the Department of Health, because we don't actually have that letter. But I'm hearing that this would be in conflict and we would have to hire people, but this is existing information. And I think Delegate Morgan just spoke to the fact that it's already on the website. I think our bill proponent also spoke to that, that people already know about this, but Mr. Cohen, you then talked about adding ketchup and how nobody would know that it was so much sugar added by adding the ketchup. And also that this might be a deterrent for people going to the restaurants, but then you gave us the example of all of these other disclosures about seafood and meat, and so it doesn't sound like it's a detriment. So have you shared your opposition
with the bill sponsor, and can you clarify what it is?
Thank you, Madam Chair. We have not shared our opposition with the bill sponsor because this is a new issue for us, and so it took us a while to get feedback from restaurant operators. We reached out to chain restaurants to ask them how this would impact their operations, and that's why I brought Mr. Cohen along with me today. But you did summarize a lot of our key concerns about the information already being available because of the federal menu labeling law that includes total sugars and sodium information, and we also have concern about creating different thresholds for brands that operate in multiple states. It would be confusing for the customers and also create different patchwork of state-based specific thresholds for things like sugar and sodium. And I would note that in the federal guidelines for sodium, the recommended daily allowance is 2,300 milligrams. This bill is half of that at 1,150, whereas New York is different, basing it on those that exceed the federal recommended allowance. On sugars, the same thing. This bill would be half the grams. And thank you, Delegate Warman, for making that clarification regarding grams versus milligrams. And that would be inconsistent with the federal guidelines, which is at 50 grams. And so there would be a lot of issues among the chains for trying to comply with state-specific guidelines. We prefer the uniformity of federal standards.
So just to clarify, you would not be opposed if it was the federal standards that were reflected in the menu? And are the federal standards what are reflected in the New York law? And have you talked to any restaurants that have chains both in New York and Maryland on how this would impact them?
I have not spoken, Madam Chair, to any restaurants that operate in New York. We are still getting feedback from our chain restaurants, but I have not spoken with my counterpart at the New York Restaurant Association. But with regard to what this bill requires, the information that we're already providing on sodium, sugar, and other nutrients as required under the federal menu labeling law is one issue. This bill in particular would require warning icons on the menu for those items designated exceeding the thresholds for sodium and sugar. That's different than the information that we normally provide. That is the information that we aren't sure if there's a public health benefit because of the reprinting of menus and carry-out, which Mr. Cohen mentioned, third-party delivery, all those things that would be required for the warning icons. We're not sure, as the data has suggested, that would consistently change consumer behavior.
Okay. Thank you for your testimony, and thank you for answering my questions. That does help clarify why we were a little inconsistent. So I appreciate that you're still seeking feedback, and I hope that you will continue to engage with the bill sponsor
and other stakeholders. Yes, ma'am, we will.
Yeah, start to engage. Thank you very much for your testimony. This concludes the bill hearing on House Bill 1048, and we're now going to move to House Bill 866. This is Office of the Deaf and Hard of Hearing Case Management Services. Delegate Fair, I am aware that you're in the room. We're also working to accommodate some of our interpreters. So you will be next up after this bill. Delegate Kaufman, if you want to come to the table and bring your panel, and we can get started with your testimony.
My panel is virtual.
Hello, and welcome to the Health Committee. Delegate Kaufman, you can get started when you're ready. We do have your virtual witnesses in the meeting now.
Thank you. And to make an analogy, Madam Chair, I took my bill to the legislative barber shop over the weekend and gave it a big haircut. Because I significantly trimmed my sails to respond to concerns from the Governor's Office of the Deaf and Hard of Hearing and the fiscal note. So I am Delegate Aaron Kaufman, and I respectfully request a favorable report on HB 866, the Office of the Deaf and Hard of Hearing Case Management Services as amended. The bill was originally introduced as a case management proposal based on recommendations from the work group for the deaf, deafblind, and hard of hearing recommendation report. However, following discussions with the Governor's Office of the Deaf and Hard of Hearing, we discovered there are other issues that still need to be researched and examined by the work group before any legislative activity is taken. Therefore, my revised bill is now seeking to extend the work group through December 31st, 2028, with a final report due by December 1st, 2028, because it expires this June. The work group was originally created by a bill that I introduced in 2024 that was passed by this committee, and ultimately passed the whole House and Senate. The work group was established to examine systemic service gaps impacting deaf, blind, and hard of hearing Marylanders. The report highlighted persistent barriers in behavioral health, access to transportation, interpreter coordination, employment services, and cross-agency case management, which is why I originally went for the case management. The work group has made progress and already generated one concrete recommendation for this session. For instance, one of their recommendations was to rename the Governor's Office of Deaf and Hard of Hearing to the Governor's Office of Deaf, Blind, and Hard of Hearing, and that to accurately reflect the constituent it serves. And that bill will be on third reader on Thursday. That's HB 439. This reflects that the recommendations are producing concrete legislative results. However, structural questions remain regarding long-term sustainability in terms of case management. And so with the fiscal situation the way it is, rather than implement structural changes prematurely, HB 866 allows the work group to complete a comprehensive, data-driven evaluation and deliver fiscally responsible recommendations. And it's my understanding from my chief of staff that the amendments were sent to the Health Committee. It's important to highlight that the revised HB 866 can be financially supported using existing resources from the Governor's Office of the Deaf and Hard of Hearing. For these reasons, I respectfully request a favorable report on House Bill 866 as amended. Thank you, and I'm happy to answer any questions.
Thank you, Delegate. And Vicki Porter is testifying on this bill, and am I correct that Ursula is here for questions and information? All right. Ms. Porter, if you want to go ahead and begin your testimony.
Okay, thank you very much. Good afternoon, everyone. I'm happy to be here to testify and advocate for this bill. I want to share a personal story about this. I used to be secretary of the MACDHH, that is the Maryland Advisory Council for the Deaf and Hard of Hearing. That group typically advises GODHH on community concerns, issues of equity, and so forth. Typically, we have our sessions. Everyone attends the sessions as a town hall session. And that takes place at every session. People can come and make comment, any community concerns that arise. So one social worker from a private organization brought a deaf woman to a particular session. This deaf woman, their house had caught on fire. Their kids were taken by CPS because of communication issues, and she did not have a car to provide transportation as needed. So she commented at this meeting. So MACDHH had a representative from the Department of Health and the Department of Housing, the Department of Transportation. They were present at this meeting. Once the woman made her comments, all of the representatives came to her, gave her information about how they could help support her and so forth. At the next meeting, which was 3 months later, that woman returned to thank everyone for all of the help she had received. And it was really quite eye-opening to see this. She had wonderful communication access. She got the right interpreters, not an interpreter who was not qualified. She received quality interpreting services and didn't have to try to deal with such situations without an interpreter. I share this story because this happened about 8 years ago. And I witnessed this, I saw this for myself, the importance of having a case manager, of having case management services. And that is one of the reasons that I was on this working group. I decided to advocate and support the continuation of the working group, the sustainability of this working group until December 2028. I would like this to continue because Maryland has 1.2 deaf, hard of hearing, and deaf blind citizens in Maryland. So we want to make sure that they have access to all the services that they need. Thank you so much. I'm also a board member of the Maryland Association of the Deaf. So this MDAD, Maryland Association of the Deaf, also supports this bill. Thank you.
Thank you for your testimony. And Mr. Berry, you're here for questions, correct? So I'm going to go ahead and open it up to the members. Are there any questions for this panel? Delegate Hill.
Thank you, Delegate Kaufman, and thank you to your panel. I just want to be clear, the amendments bring the fiscal note down because they simply extend, or they still require additional staff support?
No, it brings the fiscal note now because it just simply extends this work group that I established in 2020, or my bill established, we all together established it, in 2024. What happened was I really wanted to work on case management to help people like the woman that Vicky was describing, but I couldn't, my grandfather was an accountant, so I couldn't really justify a $212,000 fiscal note. And then the letter of information from the governor's office of the deaf and hard of hearing was very concerning for me. So I just decided to pursue that at a later year, and for now, just wait, just extend the work group so they can continue their work.
Great.
And by the time they come up with all their legislative recommendations in December of 2028, hopefully we'll be in better fiscal times.
Thank you. Thank you, Madam Chair.
Thank you. Are there any other questions for this panel? Seeing none, thank you very much for your testimony today. This concludes, Mr. Berry, did you have a?
Yes, hi, my name is Ursula DeBerry. I'm here in support of this. I don't have any questions. I just want to, as the director from the Governor's Office of the Deaf and Hard of Hearing, I submitted a letter of support for extension, a proposal of extending our Maryland of the Deaf and Blind of Hard of Hearing working group. This working group was established to help break down those barriers, deaf and hard of hearing individuals, and make sure that we're continuing communication access, healthcare, emergency preparedness, education, and any type of interagency coordination. It's very critical to us. So through that coordination and collaboration with our state agencies, with community organizations, and with advocacy groups, this working group creates a very meaningful service to identify those gaps. And those gaps are able to evaluate the potential areas for improvement. And so we look forward that ODHH supports this extension for the working group, for their time, for their comprehensive data collection, stakeholder engagement, development, thoughtful action, and readiness and recommendations. Because many of the issues are experience cross-agency coordinations and they need to include long-term policy considerations, it will help create further recommendations that will be well-developed and become feasible and align with Maryland's fiscal administrative framework. So this will be very helpful for our final report that we will provide the General Assembly. It'll have a more complete data information and findings. It'll help guide future decisions, and I look forward to ODHH being able to rely on that commitment of support to continue to support our deaf and deaf of hard of hearing and deafblind community. Thank you so much for this consideration, and we will continue to be available to provide additional information if you need any additional reports or questions. We're here for you respectfully, and thank you so much.
Thank you very much for your testimony, and my apologies that I misread my notes. And also, thank you for your continued work. Are there any other questions for this panel? Seeing none, this does conclude the hearing on House Bill 866. Thank you very much for your testimony. And we are going to move to House Bill 1012. This is Public Health Local Suicide Fatality Review Teams Authorization.
Madam Chair, are you okay if my panel comes up?
And I was going to say, Delegate Fair, if you want to go ahead and bring your panel, and you do have one virtual witness on your panel, correct?
Perfect. Yes, that is correct.
Okay, we'll go ahead and bring them.
Good to see you too. Absolutely. Take your time, Dylan. Madam Chair, am I okay to get started? Good. Thank you. Thank you, Chair Bagnall and members of the Health Committee. Suicide impacts all of Maryland's jurisdictions. It's a public health issue that we as a state have dedicated legislative, executive, and administrative resources towards intervening and mitigating. Building off the existing public health infrastructure for local fatality review, HB 1012 authorizes jurisdictions' health authorities to create local suicide fatality review teams similar to the pre-existing opioid fatality review teams. While there is a statewide suicide fatality review team currently in place that was created by the General Assembly in 2022, it takes really a 10,000-foot level look at our issue, does not review every single suicide fatality, and does not provide recommendations that are tailored to the jurisdiction in which the fatality occurs. They comment on this fact in their 2025 report. My bill before you today would enable local health authorities to create their own suicide fatality review team to provide in-depth analysis and timely recommended policy changes that are grounded in the local context of each death. We have worked with the Maryland Department of Health to craft legislation that ensures there's the necessary flexibility to ensure each locality can implement the teams in a way that is workable for them while maintaining the very much needed strict confidentiality for victims, and have submitted a jointly crafted amendment to this committee. It is my hope that the legislation will allow jurisdictions the ability to develop responsive strategies for mitigating suicide fatalities in their respective territories, leading to more effective local interventions at a time where mental health crises and suicidality are an all too common occurrence in every community across this state. To give jurisdictions more tools to review, address, and intervene in suicide fatalities, I urge this committee to give HB 1012 a favorable report. Thank you, Madam Chair.
Would you like us to go to your virtual witness or your?
Please, Dr. Brookmeyer first, please.
Hello, thank you. Good afternoon, Madam Chair, Madam Vice Chair, and esteemed members of the Health Committee. I'm Dr. Barbara Brookmeyer. I'm the Director of the Health Services Division of Frederick County Government, and I'm representing County Executive Fitzwater. I also am a member of MACHO, the Maryland Association of County Health Officers, and they submitted a letter that I could also speak to. So House Bill 1012 authorizes counties and municipalities to establish, if they would like to, a local suicide fatality review team. Suicide rates are too high, and our communities are facing significant mental health challenges. Maryland currently has a state-level suicide fatality review committee, but it only analyzes aggregated state-level data, data that's 1 to 2 years or more old, and is missing local trends and local context. Establishing protections for local teams would allow counties to identify community-specific risk factors and interventions, similar to the successful model used for the local overdose fatality review teams and the child fatality review teams. Individual organizations already have the information, they just can't talk about it with others. No new data systems are needed, no new storage systems are needed. For the evidence of success, again, Frederick County and the statewide, but I can speak from Frederick County's overdose fatality review team, has significantly reduced overdose deaths through multi-sector reviews that lead to the identification of and the commitment to address policy, system structures, and the environment to reduce future deaths. Local experts with access to relevant data can implement tailored strategies that work best for their communities. So this legislation, House Bill 1012, allows local jurisdictions to establish, but does not require them to establish, local suicide fatality review teams, an approach that offers the most effective, efficient, and equitable solution to identify and implement locally relevant strategies to prevent suicides, aligning Maryland jurisdictions with national best practices. We ask for a favorable report to advance House Bill 1012 and remove barriers to saving lives. Thank you.
Thank you for your testimony. And we have Travis Walter. Mr. Walter, if you want to unmute and you can begin your testimony.
Thank you, and good afternoon, Chair, members of the committee. My name is Travis Walter, and I am a clinical social worker and the Director of Crisis Services at the Mental Health Association of Frederick County. I am here in strong support of House Bill 1012. Every day in our work, we respond to people experiencing suicidal crisis. Our team answers the 988 calls, we deploy mobile crisis services within our jurisdiction, and we support individuals in our walk-in crisis care center. We see firsthand how complex suicide risk can be and how important it is that our systems work together efficiently. When a suicide occurs, it is a devastating loss for families and for communities, but it is also a moment where we should be asking, what can we learn? And how can we prevent this next loss? House Bill 1012 will allow our counties to establish our local suicide fatality review teams to examine these trends, identify gaps in services, and to better coordinate prevention efforts based on what is happening in our own communities. Maryland has used fatality review teams successfully in other public health arenas, as you have heard earlier. Applying that same approach to suicide prevention is both practical and evidence-informed and is the best step forward. This bill will help communities learn, improve, and ultimately will allow us to save lives. For these reasons, I respectfully ask for a favorable report on House Bill 1012. Thank you for your time today.
Thank you for your testimony. I'm going to open it up to the members for questions. Delegate Hill.
Thank you very much. Honorable Mayor Fitzwater, County Executive Fitzwater, could you explain what would be the advantage or disadvantage of having this as a standalone as opposed to combining it with the overdose fatality? Or maybe Delegate Fair?
Oh, wait. Yep. Thank you. Thank you so much for the question, Delegate. And our opioid overdose fatality review committee team is a perfect example of what we should be doing, looking at the unique factors that lead to opioid overdoses in our communities and what are the environmental factors of the individual community. We don't want to mix that with suicide fatality, so we want to have a separate team that specifically looks at the suicidality in the jurisdiction and then asks those same questions like they do with the opioid response team to be able to understand what are the environmental factors, what are the internal factors that are working amongst that individual, and what most importantly really is, what is it, if anything, we can do to address those issues that they're having to decrease the outcomes of those. And we see some pretty significant results in our opioid fatality review team as far as policies that we've been able to implement, as well as with our child fatality review team and the policies they've been able to implement because of those programs.
Man, I see the good work. I guess I was just asking, why not change the charge of the one that's working and say, and also review?
Yeah.
You said you don't want to, and I'm just wondering why not?
Oh, yeah, so I would just say that I think that they're two very separate issues. So we would probably, and I don't want to speak over a local health officer here, but I will say we would probably have two different teams honestly addressing those issues. So they would be two completely different meetings. Is that fair?
There'd probably be some overlap, but there would also be some unique expertise as well as the circumstances around each case that we might be reviewing that we'd bring in additional expertise.
Thank you.
Thank you.
Seeing no further questions, I just wanted to double check. You had mentioned that you're working with the department. They put in a letter favorable with amendments. Are those the amendments that you're working on with the department?
Yes, that is. Okay. Yep.
Great, thank you very much. Seeing no further questions, this concludes this bill hearing on House Bill 1012. Thank you very much for your testimony.
Thank you, Madam Chair.
And we are, do I have Delegate Solomon? Oh, yes, okay. Delegate Solomon, we are going to move to House Bill 1015. This is the Developmental Disabilities Administration Services Eligibility for Recently Relocated Individuals, Ralph's Act. You can bring your panel up, yes, and begin your testimony when you're ready.
Order we're supposed to be in.
No, that's fine. Thank you, Madam Chair, and congratulations again. It's the first time in the new Health Committee. Appreciate that. I'm sure many of you are not sad that you gave us the government operations side of things in GLE. And Madam Vice Chair, good to see you all, colleagues. For the record, Delegate Jared Solomon here to present House Bill 1015, also known as Ralph's Law. I want to just say that this is, I think, the first time that I've ever specifically introduced a bill that came out of just one constituent issue. We often, I think, in our district, as I think many of you do, we work with a lot of our constituent groups and come up with really great ideas. It's blessing and the curse representing really brilliant people is they know exactly what you're doing, but they also come up with some of the best ideas. But this bill in particular, and you're going to hear from Stephanie, who I've known for a long time, even before I was in elected office through shared work at one of the local elementary schools PTA. I don't know that I've ever had a more frustrating constituent case. I don't know, in all honesty, that I've ever been treated or had my office treated in a worse way than we were in handling this case with the Developmental Disability Administration. And I don't do that to cast aspersions on agencies. Those of you who have worked with me know that I'm the most collaborative, willing to bend over backwards to work with folks, but this literally went on for a year and a half. And at its fundamental core, as you'll hear from Stephanie, this was about trying to do what was best for a family member who has had a lifelong developmental disability, who is living with family, mom and dad in Connecticut. Mom passed away. Dad was suffering from serious health issues and essentially could no longer care for this individual. And as you'll hear from Stephanie, from her brother, what was best for the family was to get Ralph, hence Ralph's Law, here to Maryland to live with his family. And despite jumping through inordinate number of hoops, hurdling over roadblocks, from December of 2024, we were not able to resolve this case. I got engaged, Delegate Kaufman, Delegate Shetty, Senator Waldstreicher, the whole District 18 team. We were not able to resolve this with DDA until literally several weeks ago, January of 2026. All fundamentally to get services for an individual who, if he had been born and raised in Maryland, there wouldn't have been an issue. And so out of that unbelievably arduous, gut-wrenching situation, we put this bill together in partnership with our amazing friends at the ARC, the Maryland Association for Community Services, the Maryland Developmental Disability Council. I shouldn't name these groups because I'll forget somebody, but with all of our friends and partners in the disability space who I know you hear from quite a bit and are incredible advocates. And we came up with a bill that we think is fairly narrow to try to address the situation of which we know we will see more of as baby boomers age and we have loved ones who are living with family members in other states. When those loved ones can't care for those individuals with disabilities anymore, and we want to do what's best for our families to be able to bring them with their other loved ones, their caregivers here in Maryland, that they shouldn't have to wait for 10 years. And so we have attempted to carve out a situation, and I'll spare you the nuts and bolts of the bill because it's not a long bill, and I know you all do your homework in many ways more than a lot of other committees. It's about, if you have been getting, essentially the criteria we set forward was if you have been getting services under a similar waiver program in another state for at least 10 years, again, we are trying to avoid, we don't want people to game the system, but if you have a lifelong disability and you've been getting services in another state, you have a family member in the state of Maryland you will be their dependent who has resided in the state for at least 2 years. Again, Stephanie has lived here for pretty much your entire adult life. And your previous caregiver is now incapacitated. This will not make you immediately eligible for services, but it will put you into the crisis resolution category, which means there will be a reasonable period of time in which you will expect to get services. This doesn't make you then immediately Medicaid eligible. It means that DDA can essentially do a sort of preview of what category you would be placed into, confirm that all of the information is correct, and then when you establish your formal residency here, nothing in this bill would change that. You cannot be eligible for Medicaid until you exit a Medicaid program in one state, establish residency here in the state, and then go through the normal Medicaid enrollment process. That's basically the bill in a nutshell. I know MDH did not submit it in advance, and I will just be very public. I got this from them at 8:45 last night. I walked them through this bill several times in January. I reached out because I saw that they hadn't filed any testimony, and I was very surprised that they hadn't shared anything publicly on the bill. So if you do not have their letter of concern, I know you will be getting it shortly. We think we have a set of amendments that we'll share with you at the appropriate time. We don't have them officially drafted. We have just sort of our plain language red line that we think address some of the concerns about potentially, are we running afoul of maybe some of the waiver requirements by creating sort of a presumptive eligibility? That's never our intent. Again, it was just to sort of carve out a new exception into the crisis resolution category, which actually is not even laid out in statute. It exists only in COMAR. But I will say when you see this letter, they are critical of what we have proposed, but they did it themselves. And while I do not have the AG letter, one of the issues we had as we worked through this case last summer was originally DDA said to us, we can't even tell you what category Ralph would be placed in because he hasn't moved here yet. And we kept saying, well, we're not asking you to guarantee him services. We just want, based on all of the documentation that you would receive, that again, you will hear from Stephanie and the social worker that she's been working with. We just want you to tell us what would his category be? Because if you're going to place him in category 3, Stephanie may make alternative arrangements, right? If it looks like he will not get DDA services until 5 or 7 years from now, we'll figure out a way for him to stay in Connecticut. Because Stephanie works, she's got 2 kids, her husband works, we can't indefinitely put off our careers to care for a loved one. So we will make alternative arrangements. They hemmed and hawed with us, and then they admitted that they got an AG opinion internally that said they were legally able to at least tell you what category they would be placed in. Again, that selection of the category is not a Medicaid eligibility determination. It says if you come to Maryland and you establish residency and you meet Medicaid qualifications, this is the category that we will place you in, and this is the spot on the wait list that you will be in. But again, it is not a guarantee that you are then eligible for Medicaid. They have an AG's opinion somewhere within MDH that gave them that authority because, as you'll hear from Stephanie and you'll see in the written testimony that we submitted, it outlines the timeline of all of this. They made that determination, then they made an additional determination, but we kept fighting over ultimately what definition of crisis resolution was appropriate and how to define that category. At its fundamental core here, again, before I turn it over to the panel, this is about what we think is a really reasonable compromise for a small group of people that we will probably see more of, again, as folks age, but allows for reasonable folks, not anybody trying to jump the line or, find loopholes in the system, but when you have a situation where a family member needs to move to Maryland, that they are not waiting a decade for services that they have been getting oftentimes their entire life in another state. Again, it's opportunities for us to fine tune the language here, and I'm more than excited to work with you all and the MDH team to figure this out. And with that, thank you for indulging me. Would urge a favorable report, and again, thank you for your consideration of this.
Good afternoon. My name is Stephanie Hennis, and I'm here to support Ralph's Act. My brother Ralph is 41 years old. He has autism and an intellectual disability, which cause him to be self-abusive, verbally aggressive, and to engage in property destruction. For 20 years, Ralph attended a day program in Connecticut. It was a critical aspect of his care. It improved his quality of life and helped to limit his dangerous behaviors. In November 2023, our mother died unexpectedly, and my father began experiencing severe health problems that caused a car accident he did not remember. Ralph couldn't be cared for in Connecticut, so I submitted a DDA application with my father's detailed medical records and proof of Ralph's residency because his guardian, me, is a Maryland resident. After months of silence, DDA finally agreed to an eligibility interview, but then placed Ralph in the current request category, which would never result in any services being provided. Over the next year, I provided DDA with even more documentation. It was never enough. In the end, we were left with a choice to leave Ralph in Connecticut in my father's care or move him to Maryland without services. At one point, DDA asked whether Ralph had already been harmed in a car accident, as though imminent risk was insufficient. It felt like DDA wanted to make the process so difficult that we would just drop our pursuit of benefits. But that was just not an option for Ralph and our family. So after my father's repeated hospitalizations, an appeal, delegate intervention, retaining counsel, and moving Ralph to Maryland without any services, they ultimately put him in crisis resolution. But today he still has no day program. Ralph says that this makes him sad, and he keeps asking when he'll have a new program. The months of instability have taken a toll on him and my family. He's frequently agitated at night, and his yelling wakes my children. No one should have to go through this. Ralph's Act ensures that caregivers who are long-term Maryland residents like myself can actually obtain DDA services for their loved ones. Thank you.
Good afternoon. My name is Victoria Huffam, and I am a licensed clinical social worker. I am here in strong support of this bill, both as a professional who understands family caregiving systems and as someone who has watched this bill's namesake and his family navigate the very gaps it seeks to close. Over the past several months, I've helped Ralph's sister and her family care for him while they await the day program he desperately needs. I have seen what it looks like when a family does everything right, gathers documentation, contacts officials, files appeals, and still cannot get the state to act until something catastrophic has already occurred. As a clinician, I am trained to assess families under stress. What I have witnessed is a capable, resourceful family being worn down by a system that rewards waiting, that withholds help until something catastrophic has already happened. Ralph's elderly father was hospitalized twice for cardiac emergencies, and still the family was told the situation wasn't severe enough. I also bring a more personal perspective. I have a brother with a disability who lived in a group home in Massachusetts. For years, I thought about the future, about what would happen as our family aged, about whether I might one day soon need to bring him to Maryland to be closer to me. Watching Ralph's family go through this process made me think carefully about what that transition would look like and whether Maryland's system would be navigable for us. My brother passed away in January, and that question is no longer one I have to answer. But many Maryland families are asking it right now, quietly planning for a future where they become the primary caregiver for a sibling or a loved one with a disability. They deserve a clear and workable path. This is not just a human cost, it's a financial one. Crisis placements and emergency interventions are far more expensive than early planned services. Families like Ralph's and caregivers like me have taken leave from our jobs to fill that gap. That is real economic impact rippling out from every family left without support. This is a common sense fix. It allows Maryland residents to plan responsibly for a loved one with disabilities without the system working against them. I urge this committee to pass it. Thank you.
Good afternoon, Madam Vice Chair Collison and members of the committee. My name is Andy Culp, and I'm the Executive Director of the ARC Maryland. And we support House Bill 1015 because it creates a clear, compassionate road to stability for individuals who must relocate to Maryland after the death or incapacitation of a primary caregiver. The death or loss of a parent or primary caregiver is one of the most disruptive events in a person's life. That's obvious. And for people with significant support needs, this loss can also mean the immediate loss of housing and needed care. By ensuring an expedited determination and placement on the DDA waiting list in the crisis resolution category, the bill would ensure that continuity, predictability, and fairness during one of the most traumatic transitions a family can face. We believe this approach is similar to considerations given to military families who have a child with disabilities that has an IEP in another state. Maryland's part of the Interstate Compact on Educational Opportunities for Military Children, and agreements that it's designed to ease transitions for children into the state, reduce barriers to enrollment and placement for continuity of the individualized education program. So using the same concept, Ralph's Act would help to ensure that people with IDD who have relied on home and community-based services for 10 years or more in another state are not left without a pathway to support upon the need to relocate to Maryland, again, due to the loss or incapacitation of their caregiver. And I would just add that placement on the crisis resolution priority list is appropriate because one of the criteria for being placed in that category is that you have lost your primary caregiver. Another criteria is that you're homeless, which a person would likely be having just lost their primary caregiver and needing to move. So for all these reasons, we ask for a favorable report on this bill. Thank you.
Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I'm Laura Howell. I'm the CEO of MACS, the Maryland Association of Community Services. We represent over 125 community providers of developmental disability services across Maryland. And I am here in support of House Bill 1015. As you have heard, as people with IDD, intellectual and developmental disabilities, and their primary caregivers age, it is difficult to determine the next step, and oftentimes, through those challenges, not oftentimes, I misspoke, sometimes it can mean moving to another state because being with a primary caregiver that is trusted is critically important. If a parent or primary caregiver dies, the impact on a person with developmental disability is immediate and profound. Not only because of the loss, but because of the need to be able to plan for supports and services. As you've heard, House Bill 1015 creates a narrow and really compassionate pathway to address this situation for those primary caregivers who have been residents in the state of Maryland. In addition, placing eligible people in the crisis resolution category is a very reasonable approach that strikes the balance between compassion and responsible management of state resources. Maryland families who step forward during or anticipation of a crisis should not face prolonged uncertainty or unnecessary administrative barriers. For all of these reasons, we respectfully urge favorable action on House Bill 1015.
Here? Is she?
Oh, that's my chief of staff.
Right.
Just her
I know
count.
that, delegate. But just wondering if she was going to be testifying. So are there questions for this panel? We do have one virtual witness, which we'll take in a minute. Seeing none, Laura, I kind of have a question. I mean, I'm very sympathetic to the situation, so please let me put that out there. And I think what I heard you say, so I want to confirm that I understood, that, you know, because I read the letter from the Department of Health, and they have a number of concerns, but one that struck me is you know, there are a lot of people on the waiting list now in Maryland, and would this allow for people to come in, and they specifically say neighboring states, and get the services here, you know, and jump in front of folks who have been waiting? What I think I heard you say is that the crisis resolution pathway would account for that, and or account for the specific need at that moment, but wouldn't necessarily bump somebody else off the waiting list. Am I right in that, or?
Thank you, Delegate. I do think that you are correct. I don't believe that people generally leave their primary caregivers. People don't generally say, you know, until there really is a need. Parents tend to be the primary caregiver until they absolutely cannot do it anymore. So kind of this notion that people are going to flock to Maryland, particularly given the challenges that people face and that we do have a waiting list, I don't think that's going to happen. We've gotten these calls from time to time of, you know, where it really is a crisis for the person living in another state and that sibling. Siblings are the next set of primary caregivers, and if they've been Maryland residents and the person with the disability has been receiving those services for at least 10 years, you know, that is a narrow definition, and I think it is the right thing to do, because that primary caregiver is a Maryland resident. You know, it's not like an entire family is picking up and moving to Maryland and saying, oh, I want to come to Maryland for services. This is a very specific set of criteria. I hope that answers it.
Thank you. That helps. Thanks.
I was going to say, Delegate, just 2 points that I wanted to add. So we don't have an official definition of incapacitation. It's in the bill as sort of part of the criteria, but there are a number of definitions. The one that we pulled that was sort of, I think, closest to what we were trying to get, it's in COMAR in Chapter 24 on medical assistance eligibility, and it lays out essentially incapacitation, you know, mental or physical defect, an illness or impairment, which eliminates the parent's ability to support or care for the child. So we tried to make it as clear as possible that you couldn't really game this. You know, it was the drafter that we worked with suggested sort of the 2 years, a reasonable limit. I think we could say, you know, they could be a resident for longer. Obviously, in Stephanie's case, she's been a resident for 20 plus years. The other thing, I'll just point you to the fiscal note at the very end. The fiscal note team at DLS did say they felt like because of the criteria and the limiting factors, they believed it was a significantly small number of folks who might qualify for this. So I think we tried to strike that right balance.
Just before we go to the next panel, Delegate, you said you were working with the department on this legislation previously, but then this position was a surprise to you. Can you just talk about the work you were doing in advance of the hearing?
So we had been talking with them. I mean, again, it wasn't honestly until the second week of January, the third week of January, that we officially got word from DDA that Ralph was going to be moved into the crisis resolution category. And at that point, the bill was well into drafting. We didn't have an official draft back yet. We had an outline, and then, you know, the bill was dropped. I think we got this bill back literally the day before the drop deadline, so it has been in for 2 weeks, and we walked through it. We without the language, we did walk through what was in the bill. I was just significantly surprised that I hadn't heard anything from them, and frankly, I'll be honest, the way that we had been treated, I was expecting them to come to us with a, hey, we know this bill is here, we know you've told us about it, here's where we are. I'm a little disappointed that we got the letter, I mean, literally at 8:45 last night, with not a whole lot of explanation. So again, the amazing team that we're working with of advocates. We have some amendment ideas that I think touch on some of them on their concerns. It's not to say that those concerns are not legitimate. I will say there's a chunk of that letter in particular about the sort of predetermination before they become Medicaid eligible. That in particular, they told us in the fall of 2025 that they were unsure whether they were legally allowed to do that. They got an AG's opinion internally that said they were able to do the placement, the crisis categorization determination. And so my comment to them was, I want to make sure that you don't run into a situation where in another administration, an AG interprets something differently. We want to codify that protection. So part of the reason the bill says you can do the crisis placement determination in advance, again, that's not Medicaid eligibility, is because of what they told us they got from their AG. So I was particularly frustrated to see that somehow called out in this letter as running afoul of, nobody's trying to ruin the state's Medicaid waiver by any stretch. But again, I think we have some really good ideas here working and excited to work with MDH going forward to make sure that we're in a good place with this.
Thank you very much. And I will say, in defense of MDH, we have been getting a lot of guidance, and there have been a lot of changes with the Medicaid waiver programs, and I believe that we have to start the renegotiation of the waivers in this cycle. So I'm going to strongly have conversations with the department, and let's figure out how to thread that needle and make sure that we're staying within the latest guidance from CMS, because sometimes, as you know, we do get some conflicting information. And I think we have one more witness. We have a virtual witness on a favorable panel. Is that correct? This is your whole panel, correct?
This is our panel, yeah.
All right, so this concludes this panel. We do have a favorable witness who is virtual, Amanda Mummert? No. Okay, so Amanda is not in the waiting room. All right, let the record reflect that Amanda Mummert is not in the waiting room. And I believe this concludes the hearing on House Bill 1015. And we are now going to move to House Bill 1263. Let's go to 1263. This is Public Health Work Group on Postoperative Cosmetic Care. Delegate Hill, if you want to approach the table and bring your panel. Yeah. Yes. Today's theme is jump around, jump around, jump, jump, jump up, and jump down. I have a Ty Brown. Yes.
Good afternoon, Madam Chair, Madam Vice Chair. For the record, my name is Terry Hill, and I'm here to present to you and the members of the committee House Bill 1263, Public Health Workgroup on Postoperative Cosmetic Care. Many of you who have been on the committee for a few years will remember that our colleague, Delegate Martinez, presented I think last year or 2 years ago, a very memorable panel on a bill that described patients who were receiving postoperative care, not directed by their surgeons, but going to people who had advertised that they could manage patients and help them recover after surgery. And many of them were coming up with quite significant disfigurements and injuries. At that time, Delegate Martinez and I had a discussion because I thought that the questions that he raised and that the panel raised were real questions, but that the solution was in the wrong hands. So I have been working with Ms. Brown, who had come to Delegate Martinez and at the time that he brought the bill. And we have been working on how do we address a gap in medical care where we have technology that is constantly evolving with new devices, new techniques that are not regulated in statute and that we're not keeping up with in regulations, and new people entering what we considered a regulated space, offering to perform services that don't fall under any boards. That's what this bill attempts to do. It is a bill that sets up a work group of people from a variety of different medical boards to get together and trying to define this landscape. Who are the legitimate players? What certifications should be had in order to protect the public? What boards should be overseeing it, if any? And if there are certifications that should be had, if there are bad actors, how do we define them? And how do we stay current, again, with technology that continues to change? As you all know, the boards can't regulate people who aren't their licensees. So if I want to offer a service that, and it may be a good service, but we don't require any board certification for it, and you offer it and people get harmed, then that ends up being an assault. But it also ends up being a medical problem. And so what this bill does is suggest that maybe it's time for us to sit down with representations from multiple boards, again, to see if we can define what the problem is, how broad the problem is, and how best to address it.
Thank you, Chair, for having us today. Chair Bagnall, Vice Chair Cullison, and members of the HGO Committee. My name is Ty Brown, representative of the CSL Therapy Organization, and I'm here in support of Bill 1263, examining the body-altering aesthetics industry. Each year, Maryland residents undergo elective surgical procedures and are discharged within hours. Recovery includes trauma remodeling from large volume surgical procedures that separate tissue planes and disrupt so much of the body's fluid regulating networks. Patients leave surgery with altered microvascular dynamics and a high inflammatory load. When that widespread level of physiological disruption occurs, patients seek and find benefit in what has emerged over the last 20 years as a synergy of post-surgical bodywork treatments and services. And when we refer to the post-surgical care, it is specifically the ongoing bodywork care that clients are receiving months and years after they've had procedures. These services are frequently categorized as massage, yet the techniques being delivered often extend beyond what traditional massage therapy statutes were designed to address. They also do not align cleanly with existing nursing, aesthetics, cosmetology, or physical therapy frameworks. This creates a definitional and regulatory gap and public confusion. Consumers believe they are receiving one category of care, while providers operate within language that does not clearly define what is permissible and indirectly introduces negligence into client care. Regardless of opinions of the work, Maryland residents are actively seeking these services in the state of Maryland alone. For every 100,000 Google searches, 299 of them are about surgery recovery and post-surgical bodywork. When demand exists without clear definitions, oversight, or education, standards, confusion increases for everyone involved, and that confusion carries consequences. Preventable complications escalate, inconsistent training leads to variable practice standards, scope boundaries blur, families face avoidable distress, and boards are taxed with the gray areas of their licensed providers. This work study gives Maryland the opportunity to examine these scope gaps, liability exposure, educational standards, and consumer protections before further harm occurs. Maryland can address this proactively and thoughtfully, and we ask for a favorable report for House Bill 1263. Thank you.
Thank you for your testimony. Are there questions for this panel? Seeing none, Delegate Hill, I just had a question because if you could speak to, we have a letter of opposition from the Department of Health, but they have committed to working on this issue without legislation. Have they been in communication with you?
They have not, as far as, I have no personal, and I don't believe my office has heard from them either.
Okay.
But we'll certainly reach out to them and find out. But Ms. Brown has spent about a year reaching out to members of all the boards that are included in here. We're also offering an amendment to include the acupuncture board, because when they were here last week, we talked about this bill and they said, oh yes, we're seeing the same kinds of things. So we'd certainly like to have a conversation with the Department of Health about why people and representatives of multiple boards are interested in doing this, and they don't feel that it needs to be done except internally.
Thank you very much. Oh, Delegate Warman.
Thank you, Madam Chair, and thank you for bringing this bill. When we're talking about so it's post-operative cosmetic and body-altering services, are we talking about injectables as well, or no? Okay.
Well, I mean, I would say this.
Like
I know that's
Botox.
not Ms. Brown's interest, but we're not talking about those things that are regulated like Botox and fillers.
Okay.
But there are other things that are being offered. And as I mentioned, there's also technology. So she's talking about body work with hands.
Got it.
And devices.
But there are also devices and other things that are out there that, again, don't quite fall under it. Do you get it from an esthetician? Do you get it from a plastic surgeon? Can anybody buy the machine? Who gets to dictate? So I would not exclude anything, and I think it would be up to the work group to, as I said, define what the breadth is.
Okay, thank you.
Delegate Tavares.
Thank you, Madam Chair. Delegate Hill, the thing is like, okay, we can talk about the people who do it legally, right? But I think that the issue really is the folks who perform this work illegally. Are we not talking about like BBLs or things like that? And
we're not talking about BBLs, Brazilian butt lifts, because that's generally going to be performed by someone who is licensed to do the surgery. There are other people, again, if you masquerade, I mean, that's practicing without a license, right? So those are defined. We're really talking about those things that are undefined, that don't clearly fall into one category, and the purpose of the work group is to determine exactly, again, what is that landscape, because nobody seems to know. And when contact was made with plastic surgeons, estheticians, massage therapists, and their boards, what we heard was that is a problem. We see it, but that's not under us. And that's the problem we're trying to address. And if you have a follow-up at the chair's, if the chair allows it, I think Ms. Brown might have something to add.
yes. Ms. Brown, do you have something to add?
I do. Thank you, committee. When it comes to these services, there's a difference between unlicensed and non-licensed. And the scope of work that clients received after they've done the surgery is regulated, but the services that clients receive towards their body physically after these procedures falls into a non-licensed category. And we're unable to have any type of progressive development because massage therapists are not allowed to work on unhealthy tissue. They are limited by their scopes of practice for therapeutic body work on healthy clients. And by definition, our clients are not healthy after they've had some type of procedure for several months. But then nurses can't do massage therapy and body work. And estheticians, they usually work on the décolleté up. They don't work on trauma-based tissue. And this goes down the line when you look at the statutes based upon law. And it is very hard for a state, an agency, or a department to enforce a law law that doesn't exist for a group of people who kind of just developed over the years out of needs within the last 8 to 10 years. This isn't anything new. It's just we're now seeking to have some type of organized resolution, and we're unable to do that without having a work study group come together and study the needs of this very niche but very impactful community. Thank you.
Seeing no further questions, Delegate Hill, have you identified any other states that are working to regulate this space, or would that also be part of the work group?
The CSL group that Ms. Brown is a member of, they have been working at multiple states. None of the states have accepted this. And again, in full transparency, I am not sure that they are the group to be doing this, but they are the group that has identified that something should be done.
Thank you very much. Seeing no further questions, this does conclude the hearing on House Bill 1263. We're now going to move to House Bill 1106. This is the Maryland Commission on Women's Health Advancement Establishment. Delegate Taveras, if you would like to come to the table and go ahead and bring your panel. Oh, your panel is virtual, is that correct? All right, then you are enough. Go ahead and approach the table, and you can start your testimony when you're ready.
So thank you, Honorable Chair Bagnall, Vice Chair Cullison, and committee colleagues. As always, it is an honor to be part of this esteemed body. I'm here to ask for your favorable report on HB 1106 for the Maryland Commission on Women's Health Advancement and Establishment. I appear before you in strong support for HB 1106, a legislation that authorizes a statewide feasibility study on the needs of women in Maryland and lays the groundwork for a coordinated statewide women's health network. This is a cross-file of SB 19 by Senator Arthur Ellis. Maryland is a majority-minority state, yet our maternal health outcomes reflect deep and persistent racial disparities. Black women account for 32% of all births, yet represent 54% of pregnancy-related deaths. Between 2018 and 2020, the maternal mortality rate of Black women was 42 per 100,000 live births, compared to 19 per 100,000 for white non-Hispanic women. From 2021 to 2023, Black women experienced low-risk cesarean births at a rate of 35% compared to the state average of 30%, despite cesareans carrying higher risk of infection and hemorrhage. Black infants are 2.6 times more likely to die than white infants, and this gap has worsened over the last 12 years. Black women are twice as likely to die from cervical cancer and 39% more likely to die from breast cancer. These disparities are structural. They stem from systemic barriers to care, geographic isolation, economic instability, implicit bias in clinical settings, social determinants of health, such as poor housing and limited access to healthy food, and underrepresentation of Black healthcare professionals. And we all know this. So HB 1106 is a prudent and evidence-based response to this issue. It directs the state to conduct a comprehensive feasibility study, particularly in the South, where there is a high degree of lack of service, evaluate disparities, assess infrastructure gaps, and develop a framework for a coordinated statewide network for women's care. This is about infrastructure, accountability, and measurable outcomes. We cannot correct what we do not comprehensively assess. A statewide network will allow standardized protocols, coordinated referrals, better data tracking, and improved maternal and infant outcomes. Maryland has the authority and responsibility to safeguard maternal and infant health. HB 1106 provides the blueprint to do so. So I respectfully urge your favorable report. Thank you, and I'm open for questions.
Are there any questions from our members for this panel, for this witness? Delegate Gazzoni.
Thank you, Madam Chair. And maybe I just missed this, but it looks like part of the objective of the commission would be to establish a state women's hospital in Southern Maryland. So I was just curious.
We're looking to provide a woman-specific hospital, yes, primarily in Southern Maryland, yes. So that's what the feasibility study is for, to create that feasibility assessment, to see how viable it is. Given that there were, and then we want to be able to also study the opportunity to see if there is, how we can support a statewide network so that women statewide can be supported in the areas where gaps may exist. Service gaps may exist.
Yes, I think, because I'm a little confused. So, which is not unusual. So I guess my follow-up question would be, what would be the charge of the commission going forward if, like, after there's a decision on the particular thing with regard to the women's hospital, does the commission continue on after that?
Well, we have to be able to, I mean, once you have a feasibility study, is how do you create that plan to execute, and who's going to be able to fund it, who's going to be able to manage it, who's going to be able to sustain it, because there are some cost factors that are going to be driving this issue, right? And I think that it is my understanding that we need to create a case for this need, given that the last women's hospital closed in 1950. And I think that the state of women back in 1950 versus 2025 is drastically different.
Okay, thank you, Madam Chair.
Thank you. Seeing no further questions, I just wanted to give you an opportunity to comment because we have unfavorable testimony from the Maryland Healthcare Commission who are concerned about the fact that this bill sort of presupposes that a state women's hospital is a solution to the lack of OB services in Southern Maryland. Have you been in communication with the Maryland Healthcare Commission, and what is the status of those conversations?
Well, Ms. Tracy just sent me this email. I just received it. I read it over. I did reply, and I said I'm open to conversation. I want to make sure that the original bill sponsor is at the table. Because I don't want to overstep myself in this process and respect the original bill sponsor. But I do believe that we do need to have a conversation to make sure that they are set at ease. Because the first issue that I have is that there is kind of a disagreement between the Maryland Healthcare Commission and DLS on the financing. The other issue is that, like I mentioned, I think that if they feel that it needs to be, instead of having a women's only, it needs to be more family-oriented facility so that women are able to receive all services that they're eligible for, and their family, then what will that look like? But the thing is, we've got to be able to focus on women's health care in that process.
Okay, thank you very much. I'm going to strongly encourage you to have a conversation with
I agree.
MHCC and also with the Department of Health, because there is a lot of this work being done. I want to make sure that we're not duplicating effort. And I appreciate your concerns about keeping your Senate partner at the table. This concludes the bill hearing on House Bill 1106, and we're now going to move to House Bill 939. This is Delegate Rosenberg. Oh, and let the record reflect that we did not have Dr. Kashina Across in the waiting room. So we are going to move to House Bill 939, which is certificates of birth filing time period. Delegate Rosenberg, if you want to go ahead and approach the table and bring your panel, and you can get started on your testimony.
Thank you, Madam Chair and members of the committee. House Bill 939 addresses both a modern and an ancient set of circumstances that prompt the need to increase the days that a parent or parents should be allowed before they officially register the name of their child with the state authorities. I became involved in this issue because it is virtually without exception in the Jewish faith. A male child is circumcised 8 days after they're born. There are different branches of Judaism, but they all agree and adhere to the provision in Genesis that the male child, should be circumcised on the 8th day. So the current, and in Orthodox Judaism, and I'm not as sure about the other branches, the baby is not named until the 8th day. So there is a conflict between existing law and Jewish practice. We are here, that is one of the two main reasons. The midwives also have a concern not having the technology and the interaction with the hospitals and the state, that the 5-day requirement presents some obstacles for them. And that was the origin of the bill, that they came to me and said, we understand many of your constituents might also have a problem with the existing law. And that's why the bill is before you. And I will defer to counsel for the midwives, as well as Avi Lenz, who is here on behalf of Agudath Israel. Thank you. Appreciate a favorable report.
I'm happy to. Thank you, and I apologize for my tardiness, just too many hearings. Good afternoon, Madam Chair and members of the committee. Caitlin McDonough here on behalf of the Association of Independent Midwives of Maryland and Maryland Families for Safe Birth in support of House Bill 939. And thank you to Chair Rosenberg for elevating this issue for the committee. So as the delegate described, my clients are basically like kind of home birth patients, home birth maternal health practitioners. A large portion of that relatively small group is made up by the Orthodox Jewish community and kind of other unique communities, Amish, others that tend to favor home birth and also have significant numbers of children. So something that I think has been elevated to, the members of my group is, one, difficulty getting through the shorter period for the registration process because out-of-institution midwives generally don't have electronic access to the vital record system, and they're usually a sole practitioner and kind of handling quite a bit of like postpartum services in addition to other requirements under state and state requirements, and this can be a struggle to get done. But it's also that for that particular patient community where they do seek to usually be doing the naming around the 8th day, it becomes a kind of an additional double challenge. So we got to get it in by the 5th day, and what they generally do is we'll submit the registration without a name, and then they have to follow an amendment process through vital records after the point, which is difficult during that kind of sensitive postpartum period. So we recommended, I mean, we kind of looked at different options, religious exemptions, but we found that just extending the date out gave them some flexibility without having a tremendous impact on the rest of the population. My understanding is that most babies are registered within 48 hours now, and we expect that would continue. Giving this extra time just gives some flexibility for those religious traditions and for those communities seeking those specialty services. And I'm happy to answer any questions, and I think we have virtually Tova Brody joining us as well, who's both a midwife and a mother. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the Health Committee. My name is Avi Lenz, Associate Director of Agudath Israel of Maryland, representing Orthodox families and communities across Maryland. I thank you for the opportunity to support House Bill 939, a bill that would extend the filing period following birth from 5 days to 12, as mentioned. The bill has particular relevance to our community because traditionally Jewish children receive their names several days after the birth. Boys are traditionally named, as Delegate Rosenberg said, at the circumcision ceremony, which is a minimum of 8 days following the birth, and girls at synagogue services in conjunction with the Torah reading, which will also often, though not always, be more than 5 days following the birth. Specifically in the case of boys, approximately 20% of circumcisions are delayed due to medical reasons such as jaundice or respiratory issues being the most common causes. In most of these cases, the health issue is resolved and the circumcision completed along with the naming within 12 days. So the 12 days we felt would be a great way to accommodate that. Allowing parents to submit the birth certificate after the naming ceremony rather than requiring them to either choose and use the name before the traditional time of selection, which can cause family conflict and unhappiness, or requiring them to submit one birth certificate without a name and then after the naming ceremony resubmit a second one is kind of burdensome and stressful. We respectfully ask you to report favorably on House Bill 939. Thank you again for this opportunity.
Thank you for your testimony. We have one virtual witness, Tova Brody. Yeah, we're having some technical challenges today. I'm just going to give some time and grace. So Tova Brody, if you could turn your camera on and unmute, and you can begin your testimony.
She just had one.
Oh,
is what it is, yes.
All right, Ms. Brody, if you would like to go ahead and unmute, and you can begin your testimony.
Fabulous, thank you so much. My name is Tova Brody. I'm a home birth midwife, and I work and live in Pikesville with my husband and 7 children. I'm here to express my strong support for House Bill 939, which seeks to extend the time frame for submitting birth certificates from 5 days to 12 days. Becoming a new parent, it's an incredibly joyful, yet can be an overwhelming experience that I recently faced. The current deadline for submitting birth certificates can be a significant source of stress, especially for those already navigating the challenges of caring for a newborn, if you had a baby preterm before you were prepared, or if you're recovering from a traumatic delivery. In my case, if you've had 6 children and you need some time to come up with an original name for the 7th child. Our surrounding states, Delaware, Pennsylvania, Virginia, West Virginia, all have a more generous time frame, at least 7 to 10 days, recognizing the need for flexibility and understanding during this period. For religious Jewish families like myself and most of the families I serve, the 8th day after birth is when the baby's name is traditionally given. Extending the deadline would alleviate unnecessary pressure and allow families to focus on this meaningful time. Another unique perspective that I bring to the table is that of a home birth midwife. Most of us have solo practices and work independently. This can and has caused us to face significant administrative burdens and potential fines if we miss the current deadline. While a birth certificate can be submitted without a name, it sets off a cascade of complications. Parents must schedule a meeting with a notary to notarize the paperwork. You have to make an appointment at Vital Records, which can take weeks, make an appointment at Social Security, which can take weeks, and then wait for the Social Security card to come in the mail. This bureaucratic gauntlet places undue burden on new families, and it adds stress and anxiety during a vulnerable time. By allowing a more reasonable time frame for submission, we can reduce these hurdles and let families focus on what matters most, welcoming their new baby. I urge you to pass House Bill 939, providing this much needed relief for Maryland families. Thank you for your time.
Thank you for your testimony. Are there any questions for this panel from our members? Vice Chair Cullison.
Thank you, Madam Chair. I'm curious, Delegate or Caitlin, whichever, why 12 days? I mean, I'm fully in favor of this notion of extending the time period. I was just wondering why 12? Why not 14? You know, so you could essentially have 2 weeks.
Do you want to answer?
We didn't want to go too far from existing law. We didn't want to make that significant a change, so we did a week.
So you're satisfied 12 is the right? I mean, I'm fine with it. I just checking.
And I know I'm breaking
I'm not
the rules,
nervous,
but-
thank you.
But it would accommodate that. We didn't want to have it be the 8th day, and then
Yeah.
you're like,
Oh, no.
yeah. So,
Yeah.
and then we gave a little bit, and I know we mentioned some of the health reasons that can complicate that 8th day as well, too. So, and this isn't a little bit of a sweet spot. The most states do have 5. We have seen a trend toward longer, and this is kind of in the mix of those.
My suspicion is with technology these days, it can be done at any point. It's not like it used to be, so, or it shouldn't be like it used to be. Thank you.
Seeing no further questions, thank you very much for your testimony. This concludes the bill hearing on House Bill 939, and we are now going to move to House Bill 922, which is Behavioral Health Administration, Behavioral Health Program Relocation Regulations. And Delegate Hutchinson, we're going to do both of your bills back to back, so if you want to grab everything. Absolutely. So we're going to start with House Bill 922. So if you want to go ahead and bring your panel, and I do have one virtual witness for you. Is that correct?
I'm sorry, was that?
I have one virtual witness. Beth
My
Ann
virtual
Coleman.
is sitting right next to me.
All right. Well, welcome. So you can go ahead and get started when you're ready.
Excellent. So good afternoon, Madam Chair, Madam Vice Chair, members of the Health Committee. I'm Delegate Tom Hutchinson, District 37B from the beautiful Eastern Shore, here presenting House Bill 922. So the need for this bill was brought to my attention from For All Seasons, which is a fabulous behavioral health and rape crisis center over on the Eastern Shore. Many of you had the opportunity to meet with them last week at our committee dinner as well. So last year, this very successful behavioral health, mental health provider was strung out on a very long, unnecessary, and expensive process to really simply move their office from one location to another location in downtown Cambridge. And this led to a long disruption of service, loss of patient access, and additional administrative expenses. So it was our initial hope that this could be done and addressed administratively with the department. My office, as well as Senator Moutz's office from District 37, were sent, both of which were ignored. So we have submitted this legislation so that other programs don't have to face this situation, and it frequently happens when, as they're growing and they need to move from one location to the other. So rather than forcing these programs to undergo a repetitive licensing process, the bill just requires the Behavioral Health Administration to establish a separate process to license a new location from a previously licensed location that's in good standing. So under these new rules, the programs can reuse the paperwork they've already filed and even receive temporary approval to operate at a new site while the final details are being sorted out. I mean, when you think about it, they're doing a great job at one location, and they simply just want to do that great job at another location, but we have created an administrative burden to be able to do that. So additionally, the state would be able to reward programs that have a history of following the rules and using a clean regulatory record as a reason to speed up the relocation even further. So ultimately, it ensures that these services will be able to be moved efficiently and effectively so they can care for the people that rely on them. I'll let Beth Ann get into some of the details of the process of what she went through. But you know, this really forced them to maintain 2 offices for almost a year and have 2 leases, additional expenses, which could be used for patient care instead of having to deal with this situation. So I understand it's interesting, the department has an unfavorable letter and also a fiscal note that's averaging about $186,000 per year. That actually shocked us when we saw that yesterday, because we're actually saying, let's take a process and make it easier and with less steps along the way. I don't think we need to hire an additional person to be able to expedite an organization that's in good standing to get them a new license. It's unfortunate, I think, that we're here today for this. But anyway, I look forward to Ms. Dorman to share her organization's experience, and I ask you for your favorable vote on HB 922. Thank you.
Madam Chair, Madam Vice Chair, members of the committee, it's great to be with you again. My name is Beth Ann Dorman. I'm the president and CEO of For All Seasons. We serve 5 counties on the midshore of Maryland, and we, over the last 12 years, have increased our population served from just under 1,000 clients to over 4,000 clients. And so with that growing population, one would understand that sometimes the office that we are operating needs to shift to a larger setting. Under the current BHA policy, when we are simply relocating an office, and as Delegate Hutchinson mentioned, we literally moved 2 streets down. We are a 40-year-old organization who has been in good standing with BHA for the entire 40 years that we've been in operation. But in order for us to move 2 streets down, expand our services, and be able to reach more members of the community, we needed to submit an application as a new applicant to BHA. Under COMAR, we already have a license to operate. The move down the street created a burden of duplicate lease payments. There was service continuity risks that we had to navigate. There's a financial burden of having to outfit 2 offices, and also several administrative inefficiencies that we believe can be solved with a modified process, streamlining the process and reducing the time that we are able to provide mental health services into the community. If there was simply a modification to the process where existing members who have a BHA license issued to them in good standing could simply say, as I said to Delegate Hutchinson yesterday, really what we need is an address change form, because we are simply moving down the street, but we are being forced to reapply as a new entity. This requires many things that become a burden to the organization, when what we are really trying to do is expand the services and ensure that mental health professionals can be delivering in these communities what our people need the most, which is mental health services. Thank you.
And Madam Chair, Ms. Hedrick is here just for questions.
Thank you very much for your testimony. Are there questions for this panel? Delegate Shalega.
Thank you, Madam Chair. I have 2 questions. The first is for Delegate Hutchinson. Now, do you think this fiscal note is high because they couldn't solve the problem and they're trying to kill the bill?
I'm not going to assume that immediately.
Not would be, but could that be?
It's a possibility, but I haven't had an opportunity to have a conversation with them. I just saw the fiscal note yesterday, but I think we should be able to figure out a way that we can do an address change for less than $189,000 a year.
Yes, and one final question for Beth Ann. How much did this cost you? Did you add it all up? That you could have had a change of address form that could have cost you nothing.
Right.
And instead, this cost you, you spitball it.
So we're talking somewhere in the range of around $50,000 for us to just simply wait. The process incurs us renting the office. We have to have all of our construction complete. We have to have all of the offices furnished. We have to have the fire marshal inspection, the CARF accreditation, which is mandatory for us to be able to operate an office. And all of that needs to be turnkey ready before we're even able to apply. The application process, when I talk about the $50,000, we have to get all of the licenses of all of our providers. We have to have them sign the application form. So there's a huge burden on the administrative team at For All Seasons to be able to submit this application. And then when we submitted the application in June, it was not until October, and it took a phone call from Senator Mouts to be able to get the application through. The only information that we received between the time that we submitted the application while we're now paying rent for 2 offices, we have clients who have been told we're moving and we have to continue to follow up to say, not yet, is that there is no time permit while we are in the review. And the review process is 3 steps. It's submitting it, it's a secondary review, and then an executive review for us to be able to simply say we can now operate in the office that's ready to roll.
Thank you.
Thank you. Vice Chair Cullison.
Thank you, Madam Chair, and thank you, Delegate, for this bill. So is it the review process that's taking a long time, that you said there are 3 visits, and these are spaced out?
It's not even visits. May I read to you what the letter from BHA said to us once we submitted the application?
Sure.
Okay. So what we get back, and this is under COMAR 1063, Community-Based Behavioral Health Programs and Service Application for Licensure. Mind you, we've had a license for 33 years in this location. All of our documents were submitted, were received. Your application will be going to our second step for our review process. While we review applications in the order in which they were received, we cannot predict the time frame, as this varies considerably given the feedback required from each provider regarding their application during the second level and executive level steps in our review process. Once a surveyor has been assigned to your file, the surveyor will contact you via email or telephone with next steps. In the meantime, and then they provide you a BHA email.
So that's the process for original licensing, right? It's the same?
It's the same process for us to just relocate an office.
Okay.
And none of our leadership or any of our providers changed in that process as well.
Okay. Thank you very much. Thank you, Madam Chair.
Thank you. You're good. Okay. Ask the same question? All right. Thank you very much. Can I just ask, and I apologize if you already said this, when you got stalled in this process, was it also while while the department was working on the 1063 regs? Because I know that's been a 2-year deliberative process.
Sure. So we have 6 offices across the 5 counties of the Midshore, and we have run into this problem with each relocation. And as I said, we were less than 1,000 clients being served 12 years ago. So over this 12-year period, we have moved all but one of our 6 offices, and we've run into this problem every single time.
Okay, thank you very much. Thank you very much for bringing this bill and for your testimony today. Seeing no further questions, I want to make sure that we're continuing this conversation with the department, because I saw the letter of opposition, and I will just posit the question: if this is not the legislation, perhaps we need to ask what is, because this seems to be a problem that should have a solution.
Can I say one more thing before I conclude?
Oh, I had another question. Was there something else you wanted to add?
Yeah. Thank you. Speaking from somebody who oversees an office staff of 100, I recognize, and I think we all recognize, that it is a difficult time and people are stressed and overworked. And one of the things that we really come to this with is the perspective that if we can cut down on the paperwork and if we can cut down on some of the burden that is being placed on BHA, this for us feels like the solution to the fiscal note that's in there. I mean, this shouldn't be such an arduous process. So really what we see is this is us coming to BHA saying, let us be helpful to cut down on your burden so that we also can then be providing services that you're supporting.
Thank you very much. Thank you for that testimony. We are going to go ahead and conclude the bill hearing on House Bill 922, and we are going to move to House Bill 1151. This is the Maryland Department of Health study on Maryland Medical Assistance Program reimbursement of hospice room and board services. This is also Delegate Hutchinson, and Delegate Hutchinson, if you want to go ahead and bring your panel.
I have the panel coming up now.
And you can start your testimony when you're ready.
Just grab a chair, and then maybe we have to pull one up. Pull one up at the end then, from the back. All right, I'll get started here. So good afternoon, Chair Bagnall, Chair Cullison, and members of the Health Committee. I'm Delegate Tom Hutchinson, District 37B from the beautiful Eastern Shore. Today I'm presenting House Bill 1151. Maryland Department of Health study on Maryland Medical Assistance Program reimbursement of hospice and room and board services. So first of all, I want to make it very clear that this bill is initially a study and a work group. It does not propose any changes or increase to Medicaid spending. And in fact, we believe the results of such a study would indicate only that a shift in costs and perhaps a reduction in costs would occur as you move from one service provider to another. So currently, Maryland Medicaid does not pay for hospice, room, and board. However, other states across the country have been able to accomplish this. And yet, there's a letter in, I think, opposition from MDH saying that this isn't possible and they're in opposition for this. And we're just trying to get a work group to say, I think we might be able to figure this out since other states have been able to do this. This is not just an Eastern Shore issue. As you'll hear, I have hospice providers from throughout the state, along with the Hospice and Palliative Care Network of Maryland, and I believe support from the Maryland Hospital Association. This is a bill that has a potential to just provide patient choice, a choice to have high-quality end-of-life services, which in the most appropriate setting, and not one that is determined just by financial constraints of Medicaid regulations. Today, Maryland Medicaid covers room and board for end-of-life patients in skilled nursing facilities, but does not provide that same reimbursement for room and board in licensed residential hospice facilities. This misalignment steers patients into costly or less appropriate settings and limits access to timely, patient-centered access to hospice care. So why does this matter? Well, Maryland ranks near the bottom nationally in hospice length of stay, undermining quality and care planning at end of life. Maryland Medicaid has one of the lowest rates in the country of beneficiaries who elect hospice benefit, significantly limiting access to hospice care for Medicaid enrollees. I think this one is interesting that hospice has a 1.4 readmission rate versus over a 19.2% for skilled nursing facilities. And often we're seeing that they're being sent to a skilled nursing facility, then sent back to the hospital, then exacerbating our ED wait times, and then coming back. And often when they finally make it to the hospice, it's really too long in that cycle and something that should have begun much earlier. A lot of this is in my testimony, in the testimony sheet. I'd rather have you hear from my panel, but really what we're trying to do here is let's sit down with Medicaid, let's put a work group together. If other states have been able to figure this out, let's be able to do this here in Maryland so that we can, eliminate those avoidable readmission rates and just take care of people during a very critical, vital time in their life. So Maryland is already paying for end-of-life room and board. It's just in the wrong setting. And reimbursing room and board for residential hospice provides better care, better outcomes, and will actually, I believe, save Medicaid dollars. So we ask for your support on House Bill 1151.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. I thank you for the opportunity to testify today. My name is Molly Kirsch, and I'm the Executive Director at Talbot Hospice on the Eastern Shore of Maryland, and I'm testing in strong support of House Bill 1151. A study of Medicaid room and board reimbursement for hospice residential facility aligns directly with Maryland's effort to control cost and reduce avoidable hospital use. Hospice care has long been shown to reduce acute care utilization. For Maryland, this is essential. A hospice house room and board benefit would help the state achieve its goals by enabling safer hospital discharges with fewer bounce backs, reduce crisis-driven ED visits, care that aligns with patient goals in a stable supportive setting, and lower total spending. It's also important to recognize that Maryland hospices outperform national average in keeping patients out of the hospital at end of life. Data shows the hospice-eligible patients living 6 months or less have a 19% hospital readmission rate in skilled nursing facilities, while patients under the care of Maryland hospices have a hospital readmission rate of just 1.4%. This is one of the strongest hospital avoidant performances in the country. Right now, Medicaid reimburses room and board only for skilled nursing facilities, not hospice houses. This forces many hospice-appropriate patients into facilities that generate higher hospital utilization and higher downstream Medicaid costs. A hospice house benefit could reverse that pattern. Hospice is not an added cost. It is one of Maryland's most effective tools in reducing hospital dependence and ensuring compassionate, patient-centered care. By supporting this study, Maryland can evaluate a path toward lower spending, fewer hospitalizations, and greater dignity for Medicaid beneficiaries. We urge a favorable report and thank you for the consideration.
Good afternoon, Vice Chair Collison and members of the committee. For the record, my name is Peggy Shimoda, and I'm the Executive Director for the Hospice and Palliative Care Network of Maryland. You have my written testimony. I just want to touch on a few highlights of this bill. So first, I want to be sure everyone is clear that hospice houses are not hospital inpatient units. General inpatient or GIP care is short-term hospital-level care for acute symptom crises. Hospice houses, by contrast, are residential, home-like settings for patients who cannot safely remain at home but do not require hospital-level care. They are lower intensity and comfort-focused environments. So, under current policy, Medicaid does cover the hospice benefit itself, meaning the interdisciplinary team services, medications related to the terminal diagnosis, equipment and supplies, regardless of the setting. However, Medicaid does not cover room and board in a residential hospice house. As a result, patients must pay privately for the room, which places this option out of reach for many low-income Marylanders. Importantly, I just want to say this bill doesn't mandate hospice placement. Patients will still choose the care setting that they prefer. But today, for many Marylanders, hospice house care is not financially accessible. Without reimbursement, the choice is theoretical. With reimbursement, it becomes meaningful. So I thank you for your time, and for these reasons, we respectfully request a favorable report. Thank you.
Slide that microphone down to Ann.
Good afternoon, Madam Vice Chair and members of the committee. My name is Ann Lovely, and I serve as President and CEO of Coastal Hospice, serving Wicomico, Worcester, Dorchester, and Somerset families. I am here in strong support of House Bill 1151. Recently, we cared for a patient whose story highlights why this bill is necessary. He was referred to hospice and appropriate for hospice admission. His family wanted hospice care and preferred placement in our hospice house. However, because hospice room and board is not routinely covered, the family did not have the means to cover that cost. They had no choice but to send him to a skilled nursing facility under his Medicare skilled benefit. He remained there for 6 days before declining further and returning to the hospital. Shortly after, he was referred back to us, this time actively dying. He was admitted to our hospice facility and passed away after just 2 hours. 2 hours. Instead of days of comfort, symptom management, and meaningful time with his loved ones, this patient experienced multiple transfers back and forth to the hospital. His family made a financially driven decision during crisis because the system left them no other option. Had this Medicaid-eligible patient been able to access hospice facility care without barriers, 6 days of skilled nursing reimbursement, a hospital readmission, additional transport, and administrative costs could have been avoided. More importantly, his family could have been at his bedside when he passed. Instead, most of his family arrived too late. House Bill 1151 closes a gap that forces families to make decisions based on coverage rather than patient wishes. It promotes appropriate care, reduces unnecessary spending, and most importantly, preserves dignity at the end of life. Thank you.
Chairman Bagnell, Vice Chair, and members of the committee, thank you very much for the opportunity to testify today. For the record, my name is Carlos Graverin. I am Assistant Vice President of Bridging Life Hospice and Palliative Care Services. Rather than going through the written testimony that you already have, I just want to elaborate a little bit on some of the comments that have already been made today. As part of a health system, we have a unique view at Bridging Life with regard to the challenges that you've heard a little bit about today. Far too often, we're seeing delays in care for patients who really need the support of hospice. This is particularly true for patients coming from minority groups, Latinos, African Americans, Asians. They tend to be underserved by hospice services in general. This is just another one of those barriers that prevents them from accessing the care. When you look at it, the ones that are needing the most support from Medicaid are obviously the most needy. And the system as it stands today puts up too many roadblocks and prevents them from accessing care appropriately. I could tell you that every single day at LifeBridge Health, we see cases where patients can be cared for in hospice. They prefer to have hospice services, yet due to placement issues and constraints, financial constraints, keeping them from accessing that care, they end up in a nursing home only to be returned back to the hospital within days and going through that cycle over and over again. So this bill isn't asking for anything great, in my opinion. It's a study to determine whether or not by making these changes, we can make it hospice more accessible to these families. And I think in the long run, we're going to find that we're going to save a significant amount of money for the health system in general. This is very much in line with the AHEAD model that we've all been talking about so much that's now in place. You know, based on the complexities of the payment processes and the overarching goals of the AHEAD model, it's a prudent step to evaluate whether aligning room and board reimbursement under Medicaid with hospice services delivery can enhance the quality of care and financial feasibility. For these reasons, Bridging Life Hospice and Palliative Care strongly supports a favorable report on HB 1151. Thank you.
Thank you for your testimony. I'm going to go ahead and open it up to our members. Question from Delegate Lopez.
Thank you, Madam Chair, and thank you for your testimony and bringing this bill forward today. So I was looking through the written testimony. There's only one unfavorable. It's from MDH. And if I were to distill their concern down, it looks like ultimately, you know, pending the results of this study, if there were to be a change, the issue is that there's no federal matching funds for this. So 100% would come from state funds, and that seems to be the issue. But other testimony I've heard, including yours, I think Carlos, right, has said that this change aligns with the AHEAD payment model, and then there's lots of cost savings when you look at the change holistically. So just want to provide an opportunity just to learn a little bit more about that, because ultimately, you know, there's a humanitarian aspect of this, but there's also the financial aspect as well.
Yeah, there's a significant cost to hospitals for readmissions. It's an issue that we face daily. I have conversations with hospital administrators on a daily basis with regard to what we can do to help avoid these readmissions to hospitals and rehospitalizations. The emergency rooms are backed up. Very often, the ICUs are full, and we can't, because again, these are the sickest patients, right? So they're taking up these ICU beds, and patients that are in emergency rooms that need ICU beds have nowhere to go because these patients are stuck sometimes for as long as 10 days trying to get approval by Medicaid to go to one of these facilities. All that can be avoided if we basically expand the locations where patients can be cared for more efficiently, and the hospice houses are one of those places. And I would argue that it's a more appropriate setting for these patients at end of life than any nursing home.
Thank you.
Thank you.
Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. My uncle was in a hospice house just a couple weeks ago before he passed away, and I can tell you it was a wonderful atmosphere, and they treated him very, very, very well. And it was very much more inviting and accommodating for the family. So do you have any idea, a ballpark of what a day in a hospice house versus a day in a nursing home would be?
So, thank you for your question. What I would say to that is that I think that's what the study will actually help us predict, right? And we all feel strongly that I think it will be a lot less, because you're talking about some very different types of care.
Okay, I didn't know if you had any kind of ballpark comparison, but
I can add to that.
We can only answer one panel's.
that's up to you.
Sorry.
Let's see if it does
Yeah,
well.
do you have anything to add, Carlos? Thank you.
Right, thank you. Yes, we're not asking for any additional compensation or reimbursement over and above what's currently being offered through Medicaid. The Medicaid system is well established. It's a bit complicated. There are certain factors that are taken into consideration to determine the patient's acuity level, and something called the RUG score is used to determine what that payment would be. It averages somewhere between $300 to $400 in our area. So we're not asking for anything over and above that. In fact, as the payment is structured now, hospices, when a patient is in a long-term care facility and they're receiving Medicaid, the minute they go on to hospice services, hospice now has to bill for that room and board, and basically as a pass-through system, pays the facility. But because Medicaid only reimburses hospice at 95% of what the facility is paying, hospices are basically subsidizing that additional 5% to the facilities in order to keep them solvent and keep their margins. Otherwise, it becomes a disincentive for that facility to recommend a patient for hospice care. So even if it were compensated at 95% of what the facilities get paid, as is now the case with Medicaid, it would still be an improvement on the system. It would remove a barrier to these patients accessing our care that's so important.
All right, thank you. Thank you, Madam Chair.
Seeing no further questions, that concludes the testimony of this panel. We do have another favorable panel, which is Heather Guerrier, Marie Monica Escalante, Brett Lininger, Will Tilburg, and Jane Cranky. You can go ahead and come up and give your testimony.
She called you. No? Yeah. Yeah. Here.
We go first. All right, good afternoon, Madam Chair, members of the committee. Will Tilburg on behalf of the University of Maryland Medical System, here today in support of HB 1151. UMS includes 11 acute care hospitals that serves all regions and communities in the state outside of Western Maryland. And hospital services are a crucial part of the care continuum, as we heard with the previous panel. And unfortunately, due to the lack of an inpatient hospice benefit, too many of our Medicaid patients are forced to spend their final days within our hospitals because, one, they can't be discharged back to their homes where they would like to be, and two, they can't afford to be admitted to a hospice house. We believe this is a disservice to these patients. They deserve to spend their final days in a hospice house or similar environment. As we just heard from Delegate Johnson, it's far more conducive, compassionate, comfortable for a distinguished end of life. I'd also like to thank Delegate Hutchinson for bringing a comprehensive bill to the study that will analyze holistically the impact of covering this reimbursement, including how it may impact other aspects of our healthcare system that are currently serving this population, such as our acute care hospitals. With that, we'd urge a favorable report. Thank you.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the Health Committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association in strong support of House Bill 1151 with the sponsors' amendments. You've heard an amazing panel before us, so I'll keep my remarks brief. We're supporting this study because it advances a more equitable and compassionate process for supporting end-of-life care, requiring the study to evaluate the feasibility. And this is an important step to closing that parity gap. As you heard the previous panel say, ensuring Marylanders have access to high-quality hospice care not only helps those patients and families by providing dignity and comfort in their last days, it can also help our hospitals decrease length of stay, avoid unnecessary emergency department and hospital utilization, as well as reducing readmission. So all of the issues that come before your committee, this is another way to assist the hospitals. This bill also aligns with the goals of the AHEAD model as we look at care outside the walls of the hospital and non-hospital settings. So it hits all the check marks of why we should focus and study this issue further. Again, we appreciate Delegate Hutchinson bringing this important and timely bill forward and look forward to a favorable report. Thank you.
Hi, Chair Bagnall and Vice Chair Collison and members of the committee. Thank you for the opportunity to testify in support of House Bill 1151. My name is Heather Guerreri, and I am the CEO of Compass, serving Queen Anne's, Kent, and Caroline counties on the Eastern Shore. Today, Medicaid beneficiaries in Maryland often lack a meaningful choice at the end of life. When room and board are not covered in hospice residential facilities, many patients are left with only one option, a long-term care facility, even when hospice residential care would better meet their medical, emotional, and personal needs. This legislation would change that. By allowing Medicaid reimbursement for room and board, patients would be able to spend their final days in a setting focused on comfort, dignity, and family-centered care without the burden of out-of-pocket costs. Hospice residential facilities are regulated healthcare providers, and hospice teams specialize in end-of-life care for both the patient and their entire family. While federal Medicaid rules limit room and board payments, states have flexibility, and several include New York and California, have already implemented CMS-approved reimbursement models. HB 1151 would align Medicaid policy with patient choice, quality outcomes, and compassionate care at the end of life. For these reasons, I respectfully urge a favorable report on HB 1151. Thank you for your time and consideration.
Chair Bagnall, Vice Chair Collison, members of the committee, thank you for the opportunity to testify in favor of HB 1151. My name is Monica Escalante, and I serve as the president of the Board of Directors of the Hospice and Palliative Care Network of Maryland, the organization that represents all hospices in the state of Maryland. I would like to directly address the concerns about the cost of conducting this study. First, it is important to emphasize that this bill does not require the creation of a new costly program. It gives Maryland Department of Health and the Maryland Healthcare Commission the flexibility to conduct a study in several ways, and I want to volunteer one idea about the many ways that it can be conducted. A practical and responsible option would be a limited pilot, using a smaller number of existing houses that are already Medicare certified and are already meeting the regulatory and operational requirements. Under this approach, participating hospice houses do not need new infrastructure or any administrative overhead. It simply gives Medicaid beneficiaries an additional appropriate setting for end-of-life care. This approach would not increase Medicare spending, in fact, would reduce it immediately. The proposal envisions a reimbursement for hospice house room and board at 95% of what Medicaid currently pays for skilled nursing or rehabilitation services in other facilities. That means Medicare beneficiary who chooses hospice residential care instead of rehab will result in an automatic 5% savings to Medicaid. Before considering any additional savings from avoided hospitalizations, emergency room departments, or others that have been already mentioned. HB 1151 allows Maryland to evaluate the cost offsets in a controlled, responsible way using real data, limited scope, and existing provided capacity rather than speculation. Finally, this bill does not mandate placement in hospice houses. It preserves patient choice. Thank you.
Thank you for your testimony. Go ahead.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Brett Leininger, today on behalf of Talbot Hospice and other hospice centers on the shore. I was here in case there was something that hasn't been covered. Think it's been covered, so me too.
That is always very acceptable and appreciated testimony. Delegate Hutchinson.
Madam Chair, not necessarily a question, but I failed to admit that this actually has an amendment. So we did amend this bill just to identify the scope of the work group's work product, so it's consistent with the Senate version. I failed to admit that this is an amended bill, and I'll make sure those amendments are at the committee.
Perfect. Thank you very much. Are there any other questions from the members? Vice Chair Cullison.
Thank you, Madam Chair. Monica, how are you?
It's so good to see you.
That's not my question. It's wonderful to see you as well. So my question is, the way that you described the financial aspects of what we're talking about, I'm hoping that you will be available to use your expertise in this study. Is that possible?
Absolutely.
Thank you. Thank you very much, and thank you for being here today.
Thank you.
Seeing no further questions, this concludes this hearing on House Bill 1151. Thank you all very much for your time and testimony. And we are going to turn to our final bill of the day, which is House Bill 1014. This is mental health law, danger to the life or safety of the individual or of others, definition, right to treatment. Delegate Woods, welcome back to the Health Committee. If you want to come up and go ahead and bring your panel, and you can get started. And am I correct, you have one virtual witness on your sponsor panel?
I have one virtual. Which one is the?
Bethany Yiser.
Yes, and then yes. And then you have my other.
And I have, yes, I have your other panelists, Philip Nash, Emmeline Ireland, Evelyn Burton, and Michael Gray.
That is correct.
And you can get started whenever you're ready.
All right, good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee, my first legislative love. I am, for the record, Delegate Jamila Woods, and I'm here to respectfully request a favorable report on House Bill 1014. At its core, this bill does one thing. It clarifies that what we mean in Maryland law when we say someone presents as a danger to the life or safety of the individual or of others. Right now, that phrase appears in statute, but it is not defined. And because it's not defined, it's interpreted differently depending on who's applying it, whether that's a clinician, a judge, a police officer, or an emergency room physician. When we're talking about decisions that affect someone's liberty, their safety, and their access to treatment, that lack of clarity matters. House Bill 1014 provides a structured definition. It states that danger means a substantial risk, whether or not the risk is imminent. And it requires consideration of the individual's current condition and, when available, their personal or individual medical and psychiatric history. It then lays out specific circumstances. First, when, as a result of a mental disorder, the individual is likely to cause bodily harm to themselves or another person. Second, the bill addresses grave disability. If an individual is substantially unable, except for reasons of indigence not arising from mental illness, to provide for basic needs like food, clothing, shelter, medical care, or safety, to the point that there's a substantial risk of serious bodily harm, illness, or death, that is, in fact, included. Finally, it recognizes substantial deterioration in judgment or reasoning when that impairment makes the individual unable to make a rational and informed decision about treatment, and that impairment is likely to result in one of the other criteria being met. This bill does not eliminate due process. It does not remove the requirement that less restrictive alternatives be considered. It does not lower the burden of proof. What it does is give decision makers clearer statutory guidance. We've heard concerns about civil liberties, and those concerns are important. Involuntary commitment is a serious step. That's precisely why clarity matters. A vague standard does not protect liberty. It, in fact, creates inconsistency. A defined standard promotes predictability and fairness. We've also heard concerns about racial disparities in emergency petitions. That also is real. Any implementation of this law must be accompanied by training and data collection so we can monitor outcomes and ensure equitable application. Clarity in the statute does not replace the need for accountability. It complements it. With respect to the fiscal note, the Maryland Department of Health does not anticipate an impact on state hospital facilities. The projected costs relate primarily to ensuring adequate court and public defender capacity if petitions increase. Ensuring representation and proper hearings is not a weakness in the bill, it is a safeguard. If there are additional proceedings, due process must be funded appropriately. We also have strong support from the Maryland Correctional Administrators Association, who see firsthand the consequences of delayed intervention. They remind us that many individuals with serious mental illness deteriorate in the community until they meet a narrow interpretation of danger and then are unable to access timely treatment. Colleagues, this is not about expanding commitment indiscriminately. It's about making sure our law reflects clinical realities and provides consistent guidance while preserving a safeguard and civil rights. For those reasons, I respectfully ask for a favorable report on House Bill 1014. Thank you. Who wants to go next?
All right, I'll go next. Hello, I'm Evelyn Burton, volunteer Maryland Advocacy Chair for Schizophrenia and Psychosis Alliance. Please look at the big picture here of the devastating consequences of our current danger standard, which prevents early treatment of psychotic illnesses and creates a highway to criminalization. Our jails and prisons are overwhelmed, as the MCA testimony states. State hospitals are also overwhelmed with forensic patients and no longer accept any civil patients, leaving high-need ER patients to cycle in and out of our community hospital, costing millions of dollars in Medicaid funds and increasing the ER waits for all. Over the last 23 years, families have asked 4 times for legislation to provide timely treatment before tragedy. Legislators wanted all the advocates to agree, which will never happen in this issue. 3 times, stakeholder groups were established, but 100% support never happened. Each year, though, the suffering and incarcerations and suicides have continued. We have enough recommendations. It is time to pass something that at least the majority can support. The first paragraph of this bill is based on the 2014 Stakeholder Group Report. Section C3 is based on the 2021 Stakeholder Group Report. And Section C4 is based on the Equitas Project Report endorsed by the Conference of Chief Justices. In 2023, when I worried about the adequacy of the amended AOT bill from this committee, Delegate Pina Melnick said, "Don't make the perfect the enemy of the good. It can be improved in the future years, but it will save lives now." Excuse me. Families asked for at least the passage of the key sections of this bill this year to reduce criminalization, suffering, and save the lives of our loved ones this year. Thank you. I am willing to take questions, though. I'll get myself together.
Excuse me. Madam Chair, Madam Vice Chair, members of the committee, my name is Michael Gray with NAMI Maryland, the National Alliance on Mental Illness, and we're here to ask for a favorable report of this bill. We thank the delegate for bringing this bill. It's an important topic, but to be clear, we know that it's a difficult topic. This is always a difficult topic because it's asking the system to balance the God-given and legal right to personal liberty with medically necessary treatment. So it's always going to be tough when it involves someone's liberty and a need for treatment. Now, the current law, as you heard Delegate Wood say, is vague. It's unclear, and that leads to inconsistent interpretation and application of the law across the state. And that's not just my opinion. It's not just NAMI's opinion. It is also the opinion of the 2021 Involuntary Commitment Work Group that was convened with 11 advocacy groups, several state agencies, and a lot of people who are here today to testify on all sides of this bill were part of that work group. And we encourage you to take a look at that report. Particularly its recommendations, because the United States Supreme Court has rightly said that every state must have some framework to determine whether or not a person is, by clear and convincing evidence, in need of hospitalization for their own welfare and the protection of others. Maryland is one state that does not provide any guidance to that degree at all. And that work group from 2021 and this bill contain pieces that would do that. So for those reasons, NAMI urges a favorable report. And I do want to say one thing, that we have no amendments in mind, but after talking to other groups, we're not real sure how the criminal justice piece of the bill will work, especially from the view of clinicians in Maryland. So we look forward to being part of a process and a discussion with members of this committee and with folks who are both favorable and unfavorable for the bill here today. Thank you so much.
Did you have Emmeline Ireland?
Yes.
Yeah, you're on the sponsor panel, and then we'll go to your virtual witness.
Oh, I thought you were going to have.
2 minutes, because he described the court hearing and what happened, and I described his death.
Okay, then why don't we take you on the next panel then?
Okay.
Why don't we take you on the next panel? We'll go ahead and take our virtual witness. Ms. Yiser, you can go ahead and unmute and give your testimony.
Hello, my name is Bethany Yiser. I'd like to share with you that an involuntary hospitalization that I had in 2007 changed my life forever. I had been an honor student at the University of Southern California, never used drugs, never even drank alcohol, ended up psychotic, paranoid, delusional, hallucinating, and it was so bad that I became homeless in the Los Angeles area, which would last for 4 years, including a lot of time hiding in libraries and lounges and eventually sleeping outside in a churchyard. One day I was so psychotic that I got involved in the criminal justice system. I was picked up by LAPD from the campus where I'd once been a good student in good standing and briefly taken to jail. Why did this happen? This happened because I was very sick. Again, psychotic, hallucinating, delusional. And nobody stepped in because nobody was able to step in. I didn't meet this very high bar. I wasn't technically an imminent danger to myself or an imminent danger to other people. So many people sleeping on the streets like I used to very badly need care. They need hospitalization. They need mandated medication. I've been living in full recovery from schizophrenia for 18 years now. I work as president of the Cures Foundation. I do independent writing and speaking about full recovery from schizophrenia and proactive treatments. We must do better for those of us who are the most vulnerable. You would not believe how many parents contact the Cures Foundation and say, help, I've been to the ER again and again and again, and they won't admit my son or daughter because they're not technically dangerous. So I ask you to seriously consider how important it is to get people the mandated care that they need. Thank you.
Thank you for your testimony. So why don't I take questions at this panel, and then we'll bring up, is it Philip Nash and Emmeline Ireland? Okay. Do we have questions of this panel? Let me start with Delegate Kipke, followed by Delegate Warman. Oh, I'm sorry. Delegate Kaufman, followed by Kipke, followed by Warman.
Yes. I want to thank everyone for sharing their very personal stories, particularly you, Ms. Eisner. My question, however, is for the sponsor. Delegate Woods, have you given any thought to how to reduce the fiscal note, or do you disagree with it? It says it's going to be at least $414,000. So I was wondering if you've given any thought about how to reduce it, or if you disagree with it, et cetera.
Actually, it is something that we're still having a conversation about, Delegate Kaufman.
Thank you, my friend. It's always good to see you.
You also, thank you.
Delegate Kipke.
Thank you, Madam Chair. Evelyn, you talked a little bit to me about additional financial issues that might relate to what the fiscal note might not be considering. Could you share some of that with the committee? And also, I am just curious, some of the parents' testimony, they just put their initials there. Can you tell us what that's about?
Certainly. Well, first of all, I'll address the initials. Many families come to me and they say, I want to testify, but usually one of two things. They're afraid of what will happen if their loved one finds out that they testified, afraid for their own lives sometimes, and afraid for just being able to live with that person if they become very angry at them. So they're unwilling to put their name down. Another case is where they don't want their loved one to know that they're interested in involuntary treatment, because sometimes if they've had to petition them and they get angry at them, they will cut off any contact with them. They don't want to lose touch with them. And so again, they like to remain anonymous. Those are probably the two most frequent. As far as the fiscal note, I'll just say that I was disappointed that they gave absolutely no rationale for where they're getting these numbers from. They expect an increase of like 1,000 people. But what they forget is they're basically serving these same people already, because they are cycling in and out of the hospital. They're serving them at commitment hearings, and they are serving them even more when they get into the criminal justice system and they have to have a public defender defending them at their competency hearing, their trial, and all the things that go along with that. And so this bill aims to basically just get earlier treatment, which will prevent so many multiple hospitalizations, because when you treat early, it's much easier to stabilize the person. The sicker they get, the longer they're going to have to be in the hospital. And the more often they'll have a relapse if they get so sick to start with. And so that also, if you can get them stabilized, they're not going to keep seeing the public defender in any capacity. So a lot of states that have passed these kind of laws pass it with no fiscal note. In fact, they expect savings, because mainly the savings come from reduced hospitalizations, and tremendous savings can come from the criminal justice system. You know, Montgomery County and Prince George's County have said 50% of their inmates in the counties have mental illness. And that's a huge cost for the counties, let alone for the hospitalizations for the state. So, you know, I don't see that they have any figures or data or research to support their numbers.
Delegate Warman.
Thank you, Madam Chair, and thank you for bringing this bill. In my day job, I work for the county, Montgomery County government, and I work a lot with the homeless unhoused populations. And there are some individuals that are unhoused that don't have mental illness and just don't want to go to a shelter. Are there any guardrails in place to make sure that we're not locking up people that shouldn't be locked up?
Sure, we actually talk about that in the legislation, and I spoke to that when we talked about it states the danger means a substantial risk, whether or not the risk is imminent, and it considers the personal, medical, and psychiatric history. Also, we specifically spoke to, I'm trying to find it in here, I'm sorry, when we talk about indigent populations.
Oh, indigent, not because of a...
Right.
Not caused by
We
mental
talked, thank you. So we're talking about that it does not apply to those who are indigent, not as a result of mental illness.
Got it. Thank you.
My pleasure. Thank you.
Delegate Johnson.
Thank you, Madam Chair, and thank you for the bill. So you mentioned AOT, which is the Assisted Outpatient Treatment Program that we have here in Maryland. So if this bill passes, how do you see that affecting AOT?
Who is that for?
Whoever's best to answer.
I'll take it. Okay. All right, so in most states that have AOT, the huge majority of people that go into AOT are petitioned in the hospital because they need to get them stabilized before they can even cooperate and participate in AOT. And so also it's two different populations. The population going into the hospital is much sicker and frankly not capable of participating in AOT until they get stabilized in treatment. And the people in AOT have to be basically considered safe to live in the community. People going in the hospital are considered not safe to live in the community either because they can't take care of themselves or they're a danger to others. So it's two different populations, but once they get stabilized in the hospital, that's the best time to put them into the AOT program.
Thank you. Thank you, Madam Chair.
Delegate Gazzoni.
Thank you, Madam Chair. I am looking at the letter from Hopkins, which is a suggested amendment. The suggestion, if you haven't seen it, is to align the definition, align your definition to Health General 10-708, which essentially, as they say here in the letter, which is a definition of essential needs or health and safety to have better, I'm sorry, I'm screwing this up. But essentially they said this might be a better language to better align with standards for clinicians. So I'm just curious if you've seen that, if you're open to that idea, and if not, then what's the mismatch there?
Sure, and we're happy to take a look at that and to make a consideration. I know there's a lot of concern specifically about using the word danger, about using the psychiatric deterioration. So those are conversations we have been having.
Thank you.
My pleasure.
Delegate Hill.
Thank you. I'm sure there'll be lots of discussion in subcommittee, but I was wondering, as you all were fashioning this, how much work did you do with Disability Rights Maryland? Were they at the table with you, or did they just see the bill after it was drafted?
Are you asking prior to the bill?
Yeah.
I cannot say we did a lot of work with Disability Rights Administration prior to the bill.
But you're open and will be having those conversations now that the bill is here?
Always open to conversation.
All right, thank you.
My pleasure.
Thank you. Seeing no further questions, Delegate Woods, would you like to stay at the table for your final two panelists?
Sure.
Okay.
Thank you so much.
So I'm going to bring Philip Nash and Emmeline Ireland to the table.
Madam Chair, do you have Dr. Richardson on virtual also?
And there were a few others
Okay.
under HLT.
Oh, okay, I didn't have it, I didn't have them as a sponsor. Are they meant to be on your sponsor panel?
Yes, I'm sorry.
Thank you for your wise approach.
Okay, so we'll bring them up as part of the sponsor panel. It's fine. I just didn't have them as the sponsor panel. You can begin your testimony.
But Dr. Richardson.
Right.
Oh, and then I have, there's a few others under.
Thank you, Madam Chair and committee members. My name is Phil Tudgetsu Nash, the stepdad of Matt Heiner, my wife Emmy here, and I will be giving sequential testimony. Our son Matt was a high-functioning young man with a steady girlfriend, an apartment, a car, and a job he loved. Through no fault of his own, he lost everything. 2 years ago, he needlessly died a painful death because of untreated schizophrenia. Though his parents tried to get him treatment he urgently needed, Maryland laws required that he consent before receiving medication. In his delusional state, he did not realize he was ill and would not consent. As his untreated disease got worse, Matt's delusions became threatening. On one occasion, to quiet the voices that tormented him, he smashed things in our house. He suspected that we, his parents, were alien lizard creatures from another planet. We went to court to help him get the treatment he needed, but thanks to Maryland's current law, he simply refused all medication when he was taken to a hospital. We sought help from Dr. David Picard, a schizophrenia expert who talked with Matt and believed that he would benefit from antipsychotic medication. Matt moved to an apartment, but soon he was evicted for starting a huge bonfire just outside the building. At the next apartment, Matt was cited by a safety inspector for disabling a smoke detector and illegally storing explosives. At the court hearing, Dr. Picard testified that Matt needed treatment. Without it, he was a risk to himself and others. Matt presented as a calm young man, arguing that the explosive material in his apartment was just below the illegal amount. The judge said he was impressed by Matt's argument and ruled from the bench that, quote, Matt has the right to remain psychotic if he so chooses, unquote. Unfortunately, those words were Matt's death sentence. Despite the explicit warnings from Matt's doctor and the fire marshal, the judge arbitrarily decided that Matt did not pose an imminent danger to himself or others. Tragically, the judge was wrong on both counts.
Good afternoon, Madam Chairman and members of the committee. My name is Emilian Ireland. I am Matthew Heiner's mother. A few months after his disastrous day in court, Matthew told us he was leaving for Colorado. I asked him, Matt, why are you going so far away? How will we visit you? Because we took him to get food. He couldn't take care of himself. He turned away from my gaze and said softly, it's for your own safety, Mom. At that moment, despite his psychotic state, our son saw and bravely named what the judge and Maryland laws refused to see. He was a danger to others. I will always be grateful that he wanted to protect us. How I wish that Maryland laws had protected him. After he'd been in Colorado only a few months, I got a phone call that my son had died by suicide, having set fire to his camper van. The raging fire could easily have spread to neighboring homes and caused many deaths. He'd already been cited for fire. What were they thinking? In the explosion, Matt received severe burns over 96% of his body. When the police arrived, Matt told them, I tried to kill myself and failed. Please shoot me. Instead, he was taken to a burn unit. The doctors realized he would not survive his horrific burns and began treating his pain while they tried frantically to contact his family. He had hours to live. They intubated him to keep his airway open, or else the pain medication wouldn't even work. They also had to make at least a dozen long and deep incisions all over the side of his body, carving him up like a sandwich. It was necessary to prevent the massive swelling of the burned tissue from constricting his lungs and circulation. At midnight, finally, unable to locate his family, they allowed his suffering to end at last. Is this the freedom to choose that Maryland law has in mind when deciding whether a floridly psychotic person may refuse treatment that both family and doctor are urgently requesting. It's cruel and barbaric to withhold treatment from a person who urgently needs it but cannot understand that they're ill. Our family must live each day knowing that if only Matt had received treatment, he might still be alive, like this lovely young woman. Feel free to ask questions. I welcome them.
We're very, very sorry for your loss.
Thank you.
Before we open it up to questions, we have one more witness for your sponsor panel. Dr. Richardson, if you can go ahead and begin your testimony.
Okay, thank you very much. Hi, good afternoon. Thank you, Madam Chairman. I'm Charles Richardson. I'm a retired psychiatrist after 32 years at Spring Grove Hospital. My support for this legislation comes from my observations that over the course of my career, the percentage of patients admitted to state hospitals with criminal charges grew from a relatively small minority to virtually 100%. I've observed how their charges, often for nonviolent offenses, significantly lengthen their hospital stay, often beyond what is clinically necessary, and add a heavy emotional burden to what's already a very stressful brain-based illness. Most importantly, with respect to this legislation, criminal charges can often be avoided if a person whose psychotic illness was clearly out of control had been civilly certified. In my view, Maryland's overly restrictive definition of dangerousness has made it easier for authorities to manage an obviously psychotic patient's disruptive behavior by jailing them for a crime rather than hospitalizing them for treatment. Broadening the dangerousness criteria could diminish one's right to not be hospitalized involuntarily, but safeguards are built into the civil commitment process: a hearing before an administrative law judge, the right to appeal, and time limits on the judgment. Once stable, civilly committed patients can be discharged without court review. Ironically, a mentally impaired person who is protected from civil commitment because he is not judged to be imminently or right now dangerous risks far greater loss of liberty if arrested on even minor charges. And tragically, it's often the ill patient's family members who are put at risk of violence if the danger indeed does become imminent in this restricted sense. Furthermore, delayed treatment worsens a patient's long-term prognosis. Delaying treatment until danger is imminent is waiting too long, both for the patient and for the community. I respectfully request that the committee approve House Bill 1014. By specifying that danger need not be imminent, it would reduce the number of patients who are burdened by criminal charges and reduce the risks inherent in delayed treatment. Thank you.
Thank you for your testimony.
Madam Chair, can I just verify that we should have 3 other virtual witnesses?
Yes, but you didn't have them listed as your sponsor panel. Do you
Oh,
want us
you
to
have them as another panel, that's fine.
Yeah, this is your sponsor panel plus Dr. Richardson.
Correct.
Is that correct?
That's correct.
Okay. There are a lot of witnesses, so we also are going to be going back and forth between favorable and unfavorable.
Thank you.
To be balanced, but I just wanted to make sure that we got all of your sponsor panel in. Are there questions for these witnesses from the members? Delegate Hill.
I just wanted to say to the two of you, and I know the chair's already said it, that we certainly are very sympathetic to your loss, and we appreciate your coming here to share that with us. Thank you.
Thank you. Thank you. I didn't mention that his younger brother was finally contacted by the doctors because he was in military records. He was serving in the Air Force. And it was our younger son, who's in that picture, who had to tell his mother that his brother had died. The whole system is so broken. The judge should not have tossed out the doctor's strong recommendation. He ignored it. He made a medical decision as a judge. Not right.
We are very sorry for your loss. This does conclude this panel. We are going to go to an unfavorable panel just to be balanced, and then we will return to our favorables. So if I can bring up McKenna Boss, Dan Martin, and Dan Rabbit.
Thank you.
And you can go ahead and start your testimony.
Okay, Madam Chair, I'll start. I'm Dan Martin with the Mental Health Association of Maryland here in respectful opposition to this bill. This bill defines danger to self or others for purposes of involuntary evaluation and commitment, as including a non-imminent risk of potential future substantial deterioration. And the question of how to define dangerous is a longstanding debate, and it's one that led the Behavioral Health Administration less than 5 years ago to lead a very inclusive process to review and recommend a new definition, and that process included consumer and family advocacy organizations, behavioral health providers, legal rights groups, people with lived experiences, hospitals, and others. And in the end, not everyone got everything they wanted, but there was a definition that was offered and was agreed to by a majority of participants. And this definition in this bill is not that definition. In fact, the psychiatric substantial deterioration piece of this bill was discussed and roundly rejected as overreaching. And I'm going to read from the report here real briefly. The issue of whether the criteria for involuntary commitment have been met in order to detain someone against their will should be based on current and acute issues present for a specific individual, not because of the possibility that the lack of immediate treatment may lead to future harm or treatment resistance. And that's because it would subject an overly broad population to involuntary commitment unnecessarily. Just because a person's symptoms are worsening doesn't make them a danger or mean that involuntary hospitalization is the clinically appropriate level of care. Predictions of future deterioration and future dangerousness are notoriously unreliable. Studies have found that clinical assessments of future dangerousness are only slightly more reliable than chance. And if trained mental health professionals would struggle to predict future deterioration, then laypersons and police, who would also be responsible for applying the standard, would struggle even more. And so we urge an unfavorable report. And if I could just in closing real quickly, Madam Chair, I want to say, I feel sympathy for the families that are speaking today too. They're terrible, horrible stories. I'm a family member as well, My sister-in-law has struggled with schizophrenia for years. It's been a really struggle for my family and my brother and others. But, I just wanted to say that, not all families feel that, this kind of going down this route, of a kind of expanding access to involuntary commitment is the right way to go. But I feel sorry for everybody, that's dealing with these issues. And I really want to work with the sponsor to kind of come to maybe some kind of common ground. So just wanted to thank you for the indulgence and pass it on.
Sure. Good evening, everyone. Madam Chair, members of the committee. For the record, Dan Rabbit, Policy Director at Behavioral Health System Baltimore. BHSP is the local behavioral health authority for Baltimore City. We stand in opposition to HB 1014. Our hearts go out to the folks who testified prior to us, the proponents. But this is a very serious issue and it needs to be balanced. If you are going to take away someone's civil liberties, potentially handcuff them and take them somewhere against their will and force them to stay there for days or weeks, it better be a really good reason. And the definition that is included in this bill actually goes beyond the definition that was proposed in 2022 that was rejected by the General Assembly. And it goes well beyond the definition that was agreed upon by the 2021 work group. The foremost issue from BHSP's perspective is the non-imminent risk and the assessment that a deterioration in symptoms will cause future risk. That is really subjective. By that definition, anyone with a serious mental illness who shows any increase in symptomology could be considered potentially at risk of being dangerous at some point in the future. That's just too broad. Several of the recommendations that came out of the work group that also have never been implemented were an emphasis on data collection, transparency, and training. We don't know if they have an issue with emergency petitions right now. We don't have an easily accessible source of information about the nature of these emergency petitions. There's already over 10,000 that occur every year in Maryland. And so that data, better training for judges and police officers and the people doing this evaluation, and a review of the recommendations from 2021 would be a much better place to start rather than this one-sided bill. So we ask for an unfavorable report for the legislation as written. Thank you.
Hello, thank you. My name is McKenna Baus. I'm an attorney who practices mental health law, and I'm here representing Disability Rights Maryland, the protection and advocacy organization for individuals with disabilities in the state of Maryland. DRM respectfully but strongly opposes this bill. The broadened definition of danger to self or others proposed by this bill, it violates the Constitution and goes against well-established law regarding the treatment of people with mental illness. Without requiring the risk of danger that an individual poses to be imminent, this bill would permit individuals to be institutionalized simply on the possibility that they might pose a threat at any time in the indefinite future, whether that is in days, weeks, months, years, or even decades from now. In O'Connor v. Donaldson, the Supreme Court held that a state cannot constitutionally confine without more a non-dangerous individual who is capable of surviving safely in freedom by himself or with the help of willing and responsible family members or friends. Already, individuals can develop advanced mental health directives outlining what should happen if they are deemed a danger as a preemptive intervention, and there are various other ways we can support and promote healthy living for individuals with mental illness in our communities without denying them their most basic right to liberty. In conclusion, we urge you to give an unfavorable report on HB 1014, but are happy to meet with the sponsor and any committee members to discuss the bill and whether there's a way to craft a definition that addresses everyone's concerns. Thank you.
Thank you for your testimony. Are there any questions from the members for this panel? Seeing none, I have a question for anyone who can answer this. Are you aware if the statewide steering committee on behavioral health and judicial settings is considering the recommendations from the 2021 report?
I haven't been a part of that.
I didn't mean to stop you.
Not that I know of. I would imagine that would be a good starting place, but I don't know if this is like where that discussion has started. There's a lot of different issues around behavioral health and criminal justice.
No, I appreciate that. Seeing no further questions, I will actually ask the question of the statewide steering committee on behavioral health and judicial settings. And we're going to now go to a favorable report. This is Laura Shears Coates, Liz Montana, and then we have, we'll go with that because then we'll have one more panel that's all virtual favorable. So this will be our in-person favorable, and you can start your testimony when you're ready.
Hello, everyone. Thank you for the opportunity to testify on this important bill today. Some of your faces look very familiar because I came here a few times on the AOT bill. So I did want to thank you guys that that's no longer an issue we have to come here for. My name is Laura Shears Coates. I first want to give you a little bit about my professional background. I hold a master's degree in social work, currently in my doctorate program for social work. I also own a mental health facility, OMHC program in the state of Maryland that currently serves 781 individuals with severe mental illness. In addition, I'm a CFRP, certified family, child, and adult residency practitioner through the Psychiatric Rehabilitation Association, and I have been working with those with severe mental illness for over 15 years. However, I'm here talking to you today on a more personal note. I had my only sibling. His name was Joshua Carey. He suffered from schizophrenia, psychosis, and also epilepsy related to a traumatic brain injury. My brother had no cognition whatsoever. I was his legal guardian through the courts, who recognized that he did not even understand what mental health illness was. He was actually granted through the Behavioral Health Administration to live in skilled nursing the remainder of his life. However, he was never identified a proper placement, which resulted in him being discharged to the community several times. In the period of 3 years, I did over 76 emergency petitions through the court. Sometimes they were granted. My brother would go to the emergency room and within 2 to 3 hours be discharged. I'd always call and say that I'm not picking my brother up. threatened to call Adult Protective Services. I didn't believe it was safe for him to come home. A judge just ordered him to come here 3 hours ago. Why are you sending my brother home? And I was always told, we're sorry, the laws prohibit us from keeping him if he's not a danger to himself or others. 3 days prior to my brother's death, I went into an Anne Arundel County courthouse. I got an emergency petition from my brother. He was released within 3 hours, again, because there was no imminent danger. 2 days later, my brother had a series of seizures and passed away. His autopsy report says failure to take medication as prescribed. My brother's schizophrenia made him paranoid and very scared of taking any medications at all, including his schizophrenia medication and his medication for his epilepsy. I do believe his death would have been preventable if we were able to get him the proper mental health care he needed. Thank you.
Thank you for your testimony, and we're very sorry for your loss. Are there any questions for this witness from the members? Seeing none, thank you very much for your advocacy. And we're going to, do I have Liz Montana here? Okay. All right, then we're going to go to an unfavorable panel. This is Michelle Livshin, Dara Johnson, and Courtney Bergen. You can go ahead and come to the table and begin your testimony.
I will begin. Good evening. My name is Dara Johnson, and I'm an associate staff attorney with the ACLU of Maryland, here in opposition to House Bill 1014. So as this bill clearly reminds us, emergency mental health treatment is important but challenging with no singular solution. Unfortunately, instead of sufficiently targeting the goal of affording treatment to those who need it most, this bill's broad provisions risk needlessly depriving the liberty of people of color, those who are unhoused, and others most vulnerable to such sweeping enforcement standards. This risk starts with the historical context of our involuntary commitment system, which is rooted in civil institutionalization that first emerged during the 19th century and regularly subjected those with disabilities, people of color, and others considered quote-unquote inferior to the terror of forced sterilization and other eugenics-driven efforts disguised as treatment. After most U.S. psychiatric hospitals closed in the 60s, the stated justification for involuntary commitment largely shifted from the purported benefit of treatment to an individual, as primarily assessed by doctors, to an evaluation of that person's dangerousness to society, as primarily decided through the courts as an exercise of the state's police power. In Maryland, this persists with a system that generally allows anyone, whether that's an officer, a mother, or a neighbor with a personal gripe, to seek the involuntary commitment of another person for emergency evaluation. This open door to seeking the deprivation of another's freedom, combined with the systemic lack of facilities and focus on providing individualized care, significantly inflames the risk that the vague and subjective concepts of danger proposed by this bill will ultimately continue the pattern of subjecting those most vulnerable to harm. With this in mind, we urge an unfavorable report on this bill and implore you all to consider the better and less restrictive alternatives for meeting the worthy goal of improving access to emergency health treatment.
Thank you, committee members, for the opportunity to be heard today. I'm Michelle Livshin, representing Honor Own of Maryland, opposed to House Bill 1014. The proposed standard would be based on a prediction of substantial risk of what might happen in the future, instead of an assessment of the current safety status and available voluntary supports, leading to an over-reliance of an already overburdened hospital system. Being emergency petitioned makes individuals in distress go through a traumatic, isolating process where they're forcibly restrained by police for transport and waiting for hours in crowded emergency rooms to be evaluated or admitted when the danger is not imminent. Worse, they leave the hospital facing the exact same scarcity of accessible community services. I would like to, in our testimony, we have stories from peers who are seeking support from loved ones and providers. And I'd like to read a quote from one of the stories. I was EP'd at 19 years old because I refused to take medication that caused troubling side effects. I didn't scream, curse, and I didn't threaten to do anything to myself or anyone else. The therapist claimed I would become a danger to myself and others. The police slammed me into the car door, handcuffed me as tight as possible, and I heard my mother sobbing behind me. In the hospital, I experienced assault, seclusion, and humiliation. I still have flashbacks, nightmares, and horrible intrusive memories. It will likely haunt me for the rest of my life. Those scars last a lifetime, creating fear, mistrust, and disconnection from the behavioral health system. In 2021, BHA's stakeholder work group met and broadly agreed that the EP process is too inconsistently applied and used inappropriately, and that the recommendation was for more training around the standard and data collection on civil commitment. Broadening the dangerous standard does not improve care. What does is making trauma-informed support services available and accessible in every community. That is how we help people stay out of the crisis cycle and move forward in their recovery. For these reasons, we respectfully urge an unfavorable report. Thank you.
Good evening. My name is Courtney Bergen, and I'm an individual who is living with serious mental illness and who has experienced involuntary hospitalization. And I'm here to ask you to oppose House Bill 1014 because it puts me and others like me at increased risk of unnecessary harm, abuse, and erroneous detention. I've experienced involuntary hospitalization in a state with a very similar standard that didn't require imminent dangerousness. And I can tell you that what it led to was me being frequently pulled out of work without cause, out of school when I was still a kid, and put in situations where I was brought to a hospital when I was not a danger to myself or others because I was maybe not taking care of myself in the ways that others thought I could or should have. What I needed instead was appropriate support in the community that helped me meet my needs. You know, someone can't take care of themselves. The solution isn't hospitalization. Hospitalization doesn't actually address that, unfortunately. What does address that is appropriate supports. And unfortunately, what this bill is doing is it's trying to solve a problem that does exist. We do have problems with access to treatment in this state, especially for people who, like me at a time in my life, weren't responsive to many of the treatments that we do have. We need solutions for that, but this bill is not the solution because it's not actually addressing that problem. Hospitalization is very quick. It's, you know, turn around, rinse, repeat. It's 3 days, 5 days, 2 weeks at this point. But it's just medicating people briefly, quite frequently, but it's not addressing these long-term systemic issues. And that's what needs to be solved. We do need solutions, but this isn't it. This bill really only is stereotyping people based on their disabilities. It's saying that because you can't take care of yourself, because you need more support, because you have a mental illness, you are dangerous, is really what we're saying here. It's changing the plain language definition of dangerousness and removing any temporal requirements for detaining somebody because of their mental illness. So for these reasons, I would ask you to oppose House Bill 1014 and issue an unfavorable report because it puts people like me in danger. Thank you.
Thank you for your testimony. Are there any questions for this panel from our members? Seeing none, thank you very much for your testimony. Sorry, Delegate Gazzoni.
Thank you, Madam Chair. I don't quite know how to word this well, so just, you know, try to figure me out, I guess. I know that there's emergency petition processes, and so maybe if you could just sort of walk me through how that works. And whether or not there's, and sort of where we get tripped up, if that makes sense.
I can do my best to answer this. So when somebody is an emergency petition, they're typically taken to a state hospital. They're unlikely, so I'm so sorry. They're unlikely to be taken to a state hospital directly from an emergency petition. Those are folks who are mostly involved in legal entanglements. Instead, they're taken to psych beds in community hospitals on observation, where they stay for 10 to 17 days, and they wait for a hearing in front of an administrative law judge who decides if they'll actually be committed or retained or released. Many times folks are released before or after the hearing because they have either been medicated to the point where they're stable enough to no longer meet the current standard, or the paperwork was so poorly handled that they get they get released on technicalities, but this only leads to them being stabilized for just a short period of time when they're then put back and they don't have any other supports or in the community.
Okay, just a quick follow-up. So would there be an expectation on your part that if there was what we often refer to as a warm handoff, so the person who's been medicated is doing better, then has access to supports to continue the medication? Is that that's a reasonable path forward? So that may not be available right now, but.
So I think that it's actually a slightly different issue than what we're talking about here, because this is when can somebody be admitted to the hospital? And that's what do we do after someone has been admitted to the hospital? This actually doesn't really deal with medication at all. Whether someone's involuntarily medicated is actually a separate threshold standard that someone has to meet after they're involuntarily hospitalized. So I think it's a little bit complicated. I do think we just need more long-term supports, and I personally don't think somebody should have to be hospitalized. There are a lot of people who may never meet the definition of imminent dangerousness, and they need support, but they shouldn't have to be hospitalized to get that support. So I actually just think we need more in general in the community to support people.
Thank you.
Delegate Hill.
Thank you, Madam Chair. I guess this question is for the young woman from the ACLU?
Yes.
Do you have any numbers on what % of EPs are actually found in favor of the petitioner, and what % the person is found that they're not incompetent and they're able to be released from?
So, yes, I do not have those numbers. I believe in the written testimony by the Office of the Public Defender, there were some statistics that were provided that do account for recent, commitment standards. I will add in terms of just where it seems your question is going with how many people are having that, are presenting through this process, but then found to not be, dangerous and then sent home. As just a general concern that we have in terms of how to even address, how to have some accountability around those issues, particularly with the fact that a lay petitioner can request, an involuntary commitment. And while in those particular cases that they do have to have a probable cause hearing, once that happens and someone is already in that space, that could be very difficult. A lot of, stigmas apply there. And so if there is, a misconduct that happens, if someone is pursuing that process for reasons of harassment or deception or things that are not consistent, seeking accountability afterwards is difficult, not only in terms of how the opportunities a person might have to actually be before the Office of Administrative Hearings. But on top of that, the immunity that's applied when folks who are asking for these petitions, if they just go based on things that are not actually substantive, there is immunity unless they're acting in bad faith. So that is, a difficulty in this process as well.
All right. Thank you for the answer. Thank you, Madam Chair.
Delegate Taveta.
Thank you, Madam Chair. I guess this is kind of the same question that I'm always asking on this particular issue. With regard to individuals that are refusing treatment in the hospital after an emergency petition, however, those around him still fear for their lives because they live with this individual. And that individual has criminal priors because of the lack of proper treatment. How do you handle those kinds of situations? How do you grapple with that?
So I can definitely start, but I will definitely defer also to my colleagues here based on the direct examples that they're able to provide. Just as I mentioned in starting out, this is a difficult area. So there isn't going to be a one-size-fits-all solution in those cases where there is serious harm that's still at risk. There are still processes available to account for that. Understandably, that having procedures in place to make sure that there's some guardrails around, vetting that and making sure that the folks who are subjected to this really serious deprivation of liberty, because it's no small thing, even if it is for 10 days until you get your hearing before an administrative judge. In that time, you can lose your house, you could lose your job, you can lose a lot. And so wanting to make sure that that there's guardrails against that, but still recognizing, of course, that there's harm that needs to be accounted for, that needs to be prevented. That is a wider issue that this bill, it's broad in the way that it could capture some of that, but it also captures so much more that it in terms of the needless deprivation that could happen here. I will.
All right, seeing no further questions from the committee, this concludes the testimony of this panel. We're going to move to a favorable virtual panel now. So if we can bring up Gina Beck, Laura Pugliano, Rayetta Michael, and Charles Richardson has already testified. So Gina Beck, Laura Pugliano, and Rayetta Michael. And Ms. Beck, if you want to go ahead and, do we have Gina? There's no Gina, so no Gina Beck? Okay, so let the record reflect that Gina Beck is not in the waiting room. So Ms. Pugliano, if you want to go ahead and unmute and begin your testimony.
Yes, hi, thank you for allowing me to testify today in favor of House Bill 1014 on the danger standard. My son became severely debilitated, catatonic, unable to walk or speak, and nearly died of starvation and dehydration because Maryland's danger standard for psychiatric emergency evaluation was a barrier to a critical hospital treatment. My son had paranoid schizophrenia. As I'm sure you've heard, that's a thought disorder that includes hallucinations, delusions, and paranoia. He was on a life-saving medicine called clozapine for about a year, during which he decided he wasn't actually sick and he removed the medicine. In April of that year, he suddenly became so symptomatic, he announced that he was going to bed and he would get up when he healed from many psychosomatic illnesses, a broken back, crushed ankles, brain tumors, etc., none of which he had. That standoff with him in bed lasted almost 2 full weeks. During that 2 full weeks, he quit eating and drinking because, with delusions, he believed the water was poisoned, the food was poisoned, etc. I sat by his bed for 2 horrible weeks, putting ice chips in his mouth, begging him to see a doctor, and as we all know, that doesn't work. When he was finally transported to the hospital, through an emergency petition that I gained at the courthouse, he refused medication at the hospital, and we had 3 court battles inside the hospital, all while unmedicated, for 13 days to remove his competency, then to decide if he was sick enough to be treated with medication over objection, and then a 48-hour appeals process. He sat in the hearings, all 3 hearings, on himself, mute, catatonic, and in a wheelchair, drooling on himself. And we were still not able to medicate him. He was sicker than he had ever been. I tried all the regular avenues. I called crisis intervention. He doesn't meet the danger standard. I said he can't get out of bed and walk now. He doesn't meet the danger standard. We tried the regular avenues. We finally got him in the hospital, and he was there 13 days without even aspirin while we paid the bill, right? And until he could be medicated over
Ms. Pagliano, I need you to
objection.
wrap up your testimony.
I am. I have one more thing. I want to ask you, what should I have done as a mother when my son went to bed and tried to starve himself to death, right? One of the absurdities of this situation is that if he had any other brain illness that caused a disability, I would be negligent in allowing him to lie there and rot away.
Ms.
rather
Pagliano,
than-
I do need you to wrap up your testimony,
Okay.
please.
In a different disability, I would have been negligent, okay? He died in 2015. I work with families all over the country, and the fear is that your child will meet the danger standard or that your child will not meet the danger standard. The standard has to be clarified, revised, so that families don't have to live this way and let someone become so critically ill that they're hospitalized for months to restore competency to the tune of hundreds of thousands of dollars. Thank you for letting me support this bill today. I appreciate it.
Thank you for your time and your testimony, and we're very sorry for your loss.
Thank you.
Ms. Michael, if you want to go ahead and unmute and begin your testimony.
Hi, my name's Rayetta Michael, and I'm co-founder of Help in the Home. We provide in-home and community care to people with severe and persistent mental illness, and we've been doing this for about 20 years. I'm here to ask for support of defining the danger standard. As it currently stands, Maryland's involuntary treatment law is funneling people with treatable brain diseases into, at best, marginalized existences in their parents' homes and homeless shelters, and at worst, into the criminal justice system and into graveyards. In my 25-year career, it blew my mind when I was thinking back over this. I've actually personally known 3 individuals who were murdered by people they cared for. The first was Dr. Wayne Fenton. He was a psychiatrist. He was a leader at National Institutes of Mental Health after being the medical director at Chestnut Lodge Hospital. That's where I knew him from. And he had written an op-ed piece for the Washington Post that said, as a society, we would never allow our aging parents with Alzheimer's disease to sleep on grates. Yet that's exactly what's happening with our adult children who have schizophrenia and other psychotic illnesses that are brain diseases. The other 2 people I knew were parents who kept their children at home for tragic consequences because they could not get them the care that they needed. I've also personally witnessed Ms. Pagliano's situation on 2 other occasions where it took the families watching their loved ones over a period of weeks get so emaciated that their limbs were swollen before the crisis team could take them in involuntarily. And they could be hospitalized. These examples and these stories are not rare exceptions. So I respectfully urge you to clarify the danger standard, pass this bill to do that. Severe mental illness is a brain disease. When individuals lack the capacity to recognize their need for treatment and cannot meet their most basic survival needs, the law should allow timely intervention. Appropriate treatment can prevent irreversible medical harm. It can
Please
prevent
wrap up your
violence
testimony.
and prevent death. It can restore individuals to lives of safety, dignity, and hope, much like Bethany Yiser you heard from earlier. Thank you for letting me testify, and I'm open to questions.
Thank you for your testimony. Are there any questions for this panel from the members? Seeing none, thank you again for your testimony and for your patience and staying with us today. We have one more unfavorable, okay, let the record reflect that Joanna Gallett is not in the waiting room. So this does conclude the bill hearing on House Bill 1014 and our bill hearings for today.